Good evening. It is a privilege to welcome you here to Ending Life at its Beginning, an interdisciplinary health ethics symposium exploring perspectives on neonatal euthanasia from philosophy, nursing, medicine, and law. We would like to thank you for joining us and extend a special welcome to the many guests who are participating online through our conference live stream. My name is Kiana Owen, and this is Rebecca Stanley. We are fourth-year nursing students from the University of Alberta, and we're thrilled to be your MCs tonight. I would like to begin by mentioning the generous sponsors that made this event possible, including the University of Alberta Faculty of Arts, Faculty of Nursing, Department of Philosophy, the Faculty of Medicine and Dentistry's Division of Community Engagement, the Cool Institute for Advanced Study, as well as St. Joseph's College and the John Doster Health Ethics Center. Thank you so much for all of your support.
We also wanted to let everyone know that this program is being recorded and will be posted on our YouTube channel once it has been edited. The name of the channel is ELAIB Symposium, so ELAIB Symposium. We will begin this evening by having 5 presentations by our lovely presenters that are at the front here. Each speaker has 30 minutes to present their topic. After our last presenter, we will hold a panel where the audience can ask questions directly to the speakers. You can ask your question through something called Pigeonhole, and the details about that are located on the bottom of your program.
In recent years, decisions about how to treat disabled and seriously ill infants have brought neonatal end-of-life practices under the public microscope, an important topic of controversy among ethicists and healthcare professionals. But recent legal events have made these debates particularly pressing in the current Canadian context. While Canada's new legal framework for medical assistance in dying does not permit the active euthanasia of never competent children, the Canadian Pediatric Society anticipates that, in light of the framework advanced in Carter v. Canada, parents of disabled or seriously ill infants may challenge the courts for right to actively euthanize their children. The Canadian Pediatric Society recent report, Medical Assistance in Dying, A Pediatric Perspective, found that 118, or 11.2%, of 1,050 pediatricians surveyed reported having exploratory discussions about MAID with parents on behalf of 419 never competent patients. Of these physicians, 18% practice neonatology. 45 respondents reported receiving explicit requests for MAID by parents on behalf of 91 children within the previous year. Over one-half of these requests pertain to neonates or infants under a year old. The ethics of neonatal euthanasia and selective non-treatment appears set to play a major role not only in upcoming discussions by parents and practitioners, but in legal and policy discussions and public debates in the imminent future. In light of this, we have invited esteemed presenters in the fields of philosophy, nursing, medicine, and law to share their insights on this highly sensitive and yet crucial topic. We are excited to welcome perspectives from both health sciences and the humanities, and for the participation of this audience, which includes professionals, academics, and students of various disciplines. Without further ado, we would like to introduce our first speaker.
So our first presenter this evening is Dr. Ubaka Ogbogu. Dr. Ogbogu is an assistant professor and the Katz Research Fellow in Health Law and Science Policy at the University of Alberta. He is cross-appointed to the faculties of Law and Pharmacy and Pharmaceutical Sciences. Dr. Ogbogu is a recipient of the Confederation of Alberta Faculties Association Distinguished Academic Early Career Award, and he has been nominated for the Faculty of Law's T.V. Miller Teaching Award. He holds a doctorate in law from the University of Toronto, a Master of Laws degree from the University of Alberta, and undergraduate degrees in law from the University of Benin, Nigeria, and the Nigerian Law School. His research and teaching interests are in torts, health law, biomedical law, and bioethics, science policy studies, legal history, legal theory, and medical malpractice law. His publications have appeared in prestigious academic journals including Nature Biotechnology, Cell, Healthcare Policy, Regenerative Medicine, and the McGill Journal of Law and Health. He frequently provides commentary to the media on health and science policy matters, and he has been involved in prominent national and international biotechnology policy-making activities. He was recently appointed to the Board of Directors of the Health Quality Council of Alberta, and he is a member of the Council of Canadian Academy's expert panel on medical assistance in dying. His book, Law for Healthcare Providers, will be released this fall. His presentation title is The Legal Status of MAID for Minors in Canada. Please join me in welcoming Dr. Ogbogu.
Thank you. Thanks. Thank you. Thanks to both of you for the generous introduction. Thank you for coming out today. Just a few disclosures. As you heard, I'm on the expert panel for medical assistance in dying, the CCA expert panel. The panel's report is coming out in December. So because of that, I can't actually have opinions on anything, which is tough for a lawyer. I want to have opinions, but I'm forbidden from having opinions on the matter so as not to cause problems for the CCA and so as not to jeopardize the report, which is going to be tabled to Parliament sometime in December. So I'm just going to present facts and try and not share my opinions. And anyone who has met me knows this is going to be very tough for me to do, but I'll try to do that. The second thing is that I actually can't stay for the panel, regrettably. I have some things to attend to that are due today that I've pushed the deadline so far and I can't push it anymore, and so I have to leave after my presentation. That's not me being rude. I would have loved to stay, and I apologize to my co-presenters. It's just something that's unavoidable. But if you have any questions for me, or you want to debate this matter further, you can send me an email, and I'll meet you anywhere and we can talk about it. I can share opinions in private, just not here. My talk is on the legal status of MAID for minors in Canada. I'm sure most of you know what MAID, or medical assistance in dying, is, but just in case there's someone who doesn't know, when we talk about medical assistance in dying, is having a healthcare professional or a medical professional provide assistance to a patient with achieving death. That's essentially what it is. Now in Canada, we have a law that says that only two kinds of professionals can do this, either a nurse practitioner or a physician. So those are the only two kinds of healthcare professionals that can provide MAID in Canada. What I'm going to be taking you through today is the landscape as it relates to minors in Canada. I'll explain the law and the recent changes in the law and what might be coming down the line in terms of MAID as it relates to mature minors. Now, if you have any other questions about any other aspects of MAID, please feel free to email me. I'm sure my email address is somewhere on the internet, and I'll be happy to answer your questions. Okay, so let's begin at what I call a necessary beginning. I've heard people say that MAID has now been, or assisted death has not been legalized in Canada. That's actually not true. At least if you talk to lawyers, that's not how we see it. We don't see it as MAID having been legalized in Canada. Assisted death remains illegal in Canada. It's a criminal offense to assist someone with dying. I know you're probably going like, what? What does that mean? But that's the truth. From a lawyer's perspective, it is in the criminal code, it's illegal. However, there's a legislation that was enacted in 2016 which creates exemptions from that criminal code offense. So the way lawyers think about it is it's illegal, but there are exceptions. This is important because what that means is that if you don't fall into the exception, you're committing a crime. So it's very important to stick to the exceptions as expressed in legislation. There's no room for playing with those exceptions. You can't, if you're not sure about it, the consequences are very severe, so you want to stay away from it. So for persons who are asking questions about MAID, it's important to think of it in this sense. Strict compliance is required to avoid being prosecuted for violating the criminal code. And what happens if you do this is you may face some jail time and possibly a fine or both because you've committed a crime. So does this exemption apply to minors? Now, the first thing is, who's a minor? A minor is someone who is not an adult, but that probably makes no sense. Sometimes I think I'm not an adult. I don't think Trump is an adult. So does the exemption apply to minors? Who's a minor? A minor is someone who has not attained the age of majority. Now, the age of majority or the age of adulthood is defined by legislation in every province and territory. In some provinces, it's 18. In some other provinces, it's 19. It is also defined differently depending on what kinds of activities you're thinking about. But generally speaking, you want to hit 18 before you even start to ask the question, am I still a minor or not? So that's the age where we start to see legislation that says you're no longer a minor. So a minor essentially is either a child, a teenager, an adolescent, a youth. Those are all the terms that we use to describe minors. So the exception doesn't apply to minors. What that means is that made for minors is still a crime in Canada. That exception I just talked about has nothing to do with minors. Minors are not included in the legislative scheme. So if you're still a minor, you can't obtain made in Canada. Now the legislation says only persons 18 years or older can fit into this exemption. So I suppose there's nothing more to talk about. I don't actually need 30 minutes. We're done. There's no made for minors. No, that's not true. There's more we can talk about. So even if a minor would otherwise meet the criteria, even if a minor would otherwise qualify for made, it's just not available to minors in Canada. And I'll explain why in a second. I know. I love that one. Yeah. I use it for nearly every presentation I do. All right. So that's one criteria, age. You have to be 18 or older. I'm going to very quickly talk about the other criteria in the legislation. Now, even if a minor meets this other criteria, that age criteria is an impediment to made for minors. So to qualify for made, you have to be eligible for public funded healthcare services in Canada, including during any waiting period. So for example, if you move from one province to the other and you have to wait to qualify for healthcare coverage in that province, you still will qualify for MAID. So this provision is there to prevent MAID tourism, essentially. So it's to prevent persons who are not Canadians or Canadian residents from showing up in Canada to obtain MAID services, similar to what people will do now if they wanted to get MAID and it wasn't available for them in Canada, or back then when it wasn't available in Canada, they would travel to Switzerland, for example, to obtain MAID. You have to be suffering from a grievous and irremediable medical condition. Now, if I had more time, I'll get into that because it's actually quite a complex criteria, something that will take 30 minutes to explain. Lawyers are still quibbling about it. But for now, all you need to know is that the condition has to be very serious, and it has to be something that cannot be relieved by any means that's acceptable to the patient. So we're talking about serious conditions where the person is at the end of life and natural death is foreseeable. So it's a criteria that is quite complex to explain, but for now, that's what it is. And you have to be able to give free and informed consent in order to be able to qualify for MAID. So even if a minor somehow met this criteria, and minors could meet this criteria in certain circumstances, which I'll explain subsequently, they still wouldn't qualify because of the age requirement. Now, the legislation says that the federal government has to initiate an independent review of 3 areas. So this is something that's set by legislation. The government has to look at whether to expand the legislation to include something called mature minors, which I'll explain in a second. Also, to look at requests by persons with mental illness as the sole underlying condition, and persons who want to obtain MAID by means of an advanced request. So people who want to fill out an advanced directive, for example, and say, you know, I want MAID in the future when I lose the capacity to make decisions. These are 3 areas that are not covered in the legislation, and the government has committed to looking at these 3 areas. So the work I'm doing on the CCA expert panel is part of the government's commitment to try and investigate these areas and see if MAID can be extended to these areas. So that independent review is ongoing. As I said, it's due out in December. The report will first be tabled to Parliament and then released to the public subsequently. So watch out for that. It's due out in December. The legislation also says that Parliament has to review the law 5 years from 2016, essentially. There's an expectation that when that review happens, the law might change. And so the question that we have to deal with now is, will that change include extending MAID to minors? And if it does, how will that look like? And that's one of the areas that the CCA panel is looking at. So what's the rationale for excluding these areas? Well, I think the rationale is that we're Canadians, and we like to take it easy with everything. You know, we like to passively aggressively get into it, not aggressively. That's a non-serious explanation. For a more serious explanation that comes from the legislation, the government considers these areas to be areas that have unique implications. And I think most people would agree that extending MAID to minors or to persons with mental illness as sole underlying condition or through an advance request seems pretty unique. So the government is saying these are areas where we feel that they're going to be socially divisive, maybe controversial, we don't quite understand them yet, and we don't have good evidence for how it's going to work one way or the other. So what we want to do is we want to take it easy. You want to, first of all, we've created an exception. What we want to do now is take some time to consider these areas because of the unique implications that they raise. As a matter of fact, the reason why you're here today is because you understand very well that this area has unique implications. And you're going to hear from my fellow presenters about some of the uniqueness that's associated with this area. Because this is Canada, we also have to strike a balance between things, right? On the one hand, there's individual autonomy and all the interests that go along with that, and societal interest in protecting the vulnerable. You would agree that minors are generally seen as vulnerable. Whether that is true or not is not important, not a debate we're going to have now, but they're seen as that. That's how we perceive them as vulnerable. We try to protect them in all kinds of ways. There's all kinds of laws that are set up to protect them. So for example, child welfare legislation is set up to protect minors, and you don't have a similar kind of legislation for adults. The idea is to strike a balance between the need to extend this healthcare service to minors, while at the same time trying to address societal interest in making sure that vulnerable minors are not taken advantage of. And lastly, suicide can have lasting and harmful effects on individuals, and I think this is true. We do have, as a society, perspectives on what suicide means. The government is thinking, if we're going to do this, especially in sensitive areas, we probably want to study this first and get some good evidence to inform what we're doing. You now understand Canadian law. You can now all take an exam in this. We have made legislation. It doesn't extend to minors. There's some reasons for it. And we can argue on both sides about whether those reasons are justified, but there are reasons that the government has given. I think the reasons are compelling. It's a unique area, and the government needs more time to look at it. They haven't said, we're not going to do this. Actually, in the legislation, they say we're committed to doing something on this as it relates to mature minors, which I'll explain in a second. But for now, let's just take our time. The rest of my presentation is going to focus on two things. The first is this. This position is actually consistent with international trends. Right? Canada is not an anomaly when it comes to this position with respect to minors. That's the first thing. The second is that it is inconsistent with how we actually use the law to determine what kinds of healthcare services minors can receive in Canada. And what I'm going to talk about here, I was going to say argue, but I can't argue. What I'm going to talk about when I discuss this is that there are similar kinds of healthcare services that minors can receive in Canada right now. It seems inconsistent to say that minors cannot get MAID because there are other serious types of decisions that we make for minors in the healthcare context that the law supports and which are perfectly legal. First, international trends. So MAID for minors is not permitted in most countries that allow MAID. So if you take the world and you shrink it down to a subset of countries that allow MAID, there's fewer countries still that allow MAID for minors. As a matter of fact, there's only 2, Belgium and the Netherlands. So, I mean, there's more countries than this that allow MAID, and if only 2 of them allow MAID for minors, we're not really alone in this. If you look at the law in both jurisdictions, though, law and practice, there's additional safeguards that are placed on MAID for minors. Minors are not eligible for MAID in the same way that adults are in those jurisdictions. MAID for minors has to meet extra requirements which are designed to be safeguards because, again, it's a unique area and there's a need to balance the need to provide this service to minors with the perceived vulnerability of minors. In the Netherlands, minors 12 years or older only. So that's the first thing, an age requirement. Now, if I was allowed to express an opinion, I might ask, Ubaka over there, Ubaka number 2 might ask, 12, 11, what's the difference? Right? Why does age matter? But I'm going to leave that for my fellow presenters to answer. But that's what it is in the Netherlands, who are able to make a reasonable appraisal of their own interests. This essentially means the minor has to be able to understand the nature of that decision to receive made. So it's looking like a consent requirement. Actual consent has to be obtained from a parent or guardian if the minor is between 12 years of age and just under 16 years of age. If you're above 16, so a day above 16 years of age, then you only consult with your parents and you don't need their consent. Now, again, if I was allowed to express an opinion, generally as law professor who teaches in this area, I don't like things that are adjusted to age. It tells us very little about how humans actually understand things and respond to things. I'm a 44-year-old man. Sometimes I behave like a kid. And I certainly know a lot of adults who can't understand anything or actually behave like adults. So it seems so strange to tie this to age, but that's what it is. This is what the law is in the Netherlands. It is factored to age. Now, in the Netherlands, they've had 13 cases of made for minors who qualify between 2003, when their law changed, and 2018. 12 to 18 years of age, so there's a spread, 12 to 18, minors in that age category, all suffering from a terminal form of cancer. So that's what you have. So not a lot of cases in the Netherlands. In Netherlands, there's also something called the Groningen Protocol, which is a directive that came up in a place called Groningen, a university. This was a physician who actually wrote this directive, and it's now become something that it's not law in the Netherlands, but it does have sort of widespread implications for how made for neonates especially is performed in the Netherlands. The protocol says it relates to euthanasia. And euthanasia, I don't know if you know the distinction between euthanasia, and I'll explain very quickly. There's 2 ways you can do made. The first is when what lawyers refer to as the killing act is performed by a healthcare professional. So the doctor or nurse practitioner actually delivers the killing act. That's euthanasia. And then there's assisted death, where the physician or nurse practitioner provides the means to the patient to do it themselves. So what they have in the Netherlands for minors is euthanasia. And under this protocol, it discusses the conditions for euthanasia in neonates, essentially, in infants. So it's very relevant to what we're talking about today. The protocol says that parental consent and consultation with physicians is required. So essentially, everyone who's involved in this has to agree that this is the right thing to do. There needs to be agreement between all parties involved. And there's 2 kinds of physicians involved: the physicians who consult on the protocol and the ones who have to confirm that the requirements have been met. It's a medical and not a legal protocol. It was devised by a physician. It is used in practice. It's not law, and the law in the Netherlands is quite different from what the protocol dictates, because as you recall, the law says 12 years or older. However, the government has committed to not prosecuting anyone who actually follows this protocol. So in essence, in the Netherlands, they have a protocol that allows for MAID in neonates. Even though it's not legal, the government has basically turned a blind eye to it because it's a protocol that follows very strict requirements and guidelines. And as long as it's performed along those lines, there's no interference with it. If you're interested in the Groningen protocol, that's a reference to it. My slides will be shared after, so if you want to read, that's it right there, but it's in very small font. You're not going to see it. But if you're interested, you can look it up. In Belgium, capable minors can obtain euthanasia. So if you're a minor and you're capable, what that means is you have to have the ability to understand the nature of the healthcare procedure and the ability to appreciate the consequences of making a decision to receive euthanasia or not. Minors 18 or under, however, face stricter qualifying criteria. There's more requirements for them. They have to be terminally ill, they have to be dying in the short term, they have to be experiencing unbearable suffering. These conditions don't necessarily apply to adults, minors have to meet stricter requirements. So there's additional safeguards for minors in Belgium. Adults need not to be terminal, just serious and incurable. But the minors have to be terminal. Again, if I was to offer an opinion, I'll ask about the difference between these. The important thing to consider here is that these minors are suffering as much as the adults. I don't know whether being terminal makes a difference. But this is also something that is in the Canadian legislation as well. And so it might be a factor if and when the law changes in Canada. Parental consent is required. You need assessment by physicians and psychologists. And so far, perhaps because of the very strict requirements you have to comply with, there have been only 3 cases in Belgium. And these cases were 9 and 17-year-olds in 2016, 2 cases, and then 1 case in 2017 involved an 11-year-old. And these were the diseases that they were suffering from when they received it. Just a few thoughts. In the Netherlands, we have 13 minors, but in total, everyone who has received MAID in the Netherlands is over 55,000. So lots of adults, just 13 cases involving minors. In Belgium, only 3 cases. So you can see that these safeguards may be having an impact on what's happening with minors in these 2 countries. And one question I want to leave you with is whether a ban is the best safeguard, right? If you're somebody who thinks this shouldn't be happening in the minor context, maybe a ban is the best way to actually ensure that doesn't happen. Now, all these other countries allow MAID. Countries and jurisdictions allow MAID in some form or the other, but not for minors. So the big point here is that in Canada, minors can receive other end-of-life interventions or interventions with similar consequences to MAID legally and ethically too, right? Here are some examples. Withdrawal or withholding of life-sustaining treatment. If the minor's healthcare team determines that the minor treatment is futile, is medically futile, and the parents consent, if everybody agrees, minor's life support can be withdrawn, and that minor will inevitably die. I think one might view that as somewhat in the same ballpark as MAID. Maybe not, but that's something that is perfectly legal in Canada, and a minor can receive that. Here's one other one: palliative sedation. This is where a physician delivers typically pain medication in doses that the physician knows might cause death. But the goal is not to cause the patient's death. The goal is to relieve suffering, right? Even though the dose is quite high. So this, again, is perfectly legal in Canada. In fact, it was endorsed in Carter. In Carter, the court said there's a difference between palliative sedation and MAID. One is to cause death, that's the intention, and the other is to relieve suffering, right? But the effect could be the same, and the minor could receive this, again, if consents are in place and the healthcare team is willing to go forward with that. The other thing you have to know about local legal trends is that mature minors, these are minors who are capable of making healthcare decisions, can actually consent to all these interventions I just talked about. And they can do so without parental consent and without approval by anyone, unless it's in a child protection context. In a child protection context, the rules are different. If a minor is deemed to be in need of protection, so if a minor, say for example, is facing mistreatment by the parents, or the parents can make a decision and the minor becomes a ward of the state essentially, then what happens there is different. I'm not going to touch on that. That's the stuff that lawyers get involved, the court gets involved, it becomes messy. But if the minor is not in protection, in child welfare context, a minor who's capable of making healthcare decisions can make a decision for palliative sedation, for withdrawal of life, without anyone's consent. So you have to wonder, if they can do that, how about MAID? Who's a mature minor? Trump, not for sure. That's who a mature minor is. A minor who is able to understand the relevant treatment information and the consequences of a treatment decision. So basically a minor who can understand what a healthcare decision entails and who's able to make a healthcare decision. This is not a matter of age under Canadian law. It's not about age. a minor any age who can understand the consequences of a treatment decision is deemed capable. It's not the same thing as emancipation, which is a term you might have heard. It's not about moving out of your parents' house. It's about being able to understand what the treatment entails and being able to make a decision. In some provinces, there's actually legislation that says minors of a certain age should be presumed capable unless they prove otherwise. What that means is that if you're a minor who is that age that's specified by legislation, doctors and nurses and other healthcare providers don't have to bother you with questions about capacity. They can assume that you're capable, just like they do with adults. When I go to the hospital, nobody asks me pesky questions about capacity. Same thing for these minors. But if you come in as a minor and you're behaving like there's something wrong with your capacity, then that's when the healthcare provider can ask you questions. So Quebec, for example, says if you're a minor aged 14 to 17, you can consent alone to medical care that's required for your state of health. So to medically necessary care. But if it's care that's very serious or elective, for example, then you may need parental consent. But for the most part, minors between ages 14 and 17 in Quebec can consent. There's similar rules in Manitoba and some other provinces. In Alberta, again, as I said before, minors who are capable, who are mature minors, can make a healthcare decision. The only exception is if it's in a child welfare context. If that happens, then a court can override the minor's decision. So what might a change in the law look like? What's coming down the line? I think realistically, based on what I just said about international trends, 2 countries, and local trends, mature minors can make decisions. I think realistically, we're only going to see an extension to mature minors. I don't think this is going to extend to neonates. Mature minors at most in Canada. I think it's possible that the Groningen protocol might be considered, but whether it's adopted or not, I don't know. The strength of it is agreement by everyone involved, and I think if the government finds that compelling, they may adopt it because there's agreement all around that this is the best thing for the minor. You should expect to see some very Canadian safeguards. I think we're going to outdo Belgium and Netherlands. That's my sense. The one thing I haven't talked about so much, but I think we need to pay attention to, is other end-of-life care options. And in this country, we do very poorly with this. In fact, it's dismal. And I think this is an opportunity, since we're now all interested in end-of-life care, for us to revisit it and think about how we might make other end-of-life care options available within our system. Thank you for listening.
Our next speaker is Dr. Paul Byrne. Dr. Byrne is the director of the NICU at the Grey Nuns Community Hospital, a neonatologist in the Northern Alberta Neonatal Intensive Care Program, and clinical professor in the Faculty of Medicine and Dentistry at the University of Alberta. His work in the NICU consists of administrative duties, clinical service, and teaching residents, nurses, and medical students. Dr. Byrne is involved in research projects on ethical decision-making in perinatal medicine. In addition, he is an expert consultant for the Health Ethics Consultation Services at the University of Alberta, Stollery Children's Hospital, and the Mazikowski Alberta Heart Institute. He also teaches health ethics to a wide variety of healthcare professionals and lay groups. We are fortunate to have him here tonight. His presentation title is Perspectives on Neonatal Euthanasia from an NICU Physician. Please welcome Dr. Byrne.
So I'm going to try and talk to you tonight as a practicing newborn intensive care doctor, to give you somewhat of a personal view of this whole area, to also look at things in general as to how neonatology might be viewing this currently and might view it in the future. So it's a mixture of a personal take on it from somebody who's been doing this for 35 years or so, and less of a kind of review of current practice and protocols, etc. We didn't actually collude in any way, the speakers, so I was kind of wondering how much we would cross over, and I was pretty sure that somebody would bring up the Groningen protocol. I wasn't very keen to get into it, but I guess I will have to get into it now a little bit. So clearly the major difficulty when you're talking about newborns or infants in general is who speaks for them. because they can't obviously speak for themselves. And I like the fact that the word is derived from the Latin for unable to speak. And for those of you who have any connection with pediatrics in general or critical care for youngsters, even up into early adolescence, you'll recognize that parents, healthcare practitioners, family, extended family often have quite important roles in trying to figure out what to do in difficult situations. And it's only when those difficulties are irresolvable that the state gets involved. So in the NICU in the Western world, some parts of Asia, you've got three general populations of very sick babies for whom this whole question might come up. The first would be premature babies, but a tiny fraction of the premature babies. So the vast majority of premature babies who are born, even if they're very sick, get well within a matter of days. They may spend weeks or months in the NICU because they're so premature, and that's one of the things that's difficult to explain to parents and to students in general, that they're not in the NICU for 3 months because they're critically ill. They're there for the most part because they're simply not mature enough to be able to continue life on their own, meaning without special feeding and all kinds of basic assistance, but not with critical life support. And that's an important point, because if you're in an adult intensive care unit or a pediatric intensive care unit for 3 months, you are critically ill, and your chances of survival diminish with time as you spend weeks and months in those kind of ICU settings. The second big group of babies in the ICU are babies who are born more maturely. They may be also premature, but for the sake of clarity, let's say they're, for the most part, mature, because there are far more mature babies born than premature babies overall. And they've been perfectly fine until something goes wrong, either with the pregnancy, the mother gets ill, or during the process of childbirth, so during labor and birth itself. In this group of babies, you have a situation that happens often very acutely, very critically, and changes the dynamic of what's been the understanding of the parents in a matter of minutes or hours. And then the third group of babies, and these babies would be then critically ill at birth, end up being resuscitated by the NICU team and admitted to the ICU. And then the third group of babies are babies for whom the problem has been diagnosed earlier in the pregnancy. So this is an intrinsic abnormality with the baby, either a congenital malformation or some genetic syndrome or other. So death in the ICU today is very uncommon. The vast majority of babies in newborn ICU survive, and the vast majority of survivors go on to live normal lives. The two areas where death is most predictable are at the extreme of prematurity, and today that is at 22, 23, 24 weeks gestation. And if you remember, that term is 38 to 42 weeks gestation. So you're just barely over halfway through a pregnancy at 22, 23, 24 weeks. The other group of babies for whom death is much more significant in terms of risk are babies who are born with multiple congenital abnormalities, either as part of a syndrome or just a collection of abnormalities. And I emphasize this because the likelihood of these babies dying in the past was virtually 100% for both of these groups. And the difficulty over time, and even a relatively short span of time, as in 6 to 12 or 18 months, is that the mortality statistics or the survival statistics continue to change rapidly. So that in the past, and not only when I was training 100 years ago, there was a clear definition of X, Y, and Z conditions are lethal. And there are even textbook descriptions of, for example, lethal genetic syndromes called the lethal trisomies. Those trisomies are no longer necessarily lethal because we can do things to fix the life-threatening aspects and the children will survive. So there are two kinds of death in the newborn ICU. Early death occurs in a matter of hours or days and is generally due to the failure of life-supporting treatment. It's seen in those two groups that I described earlier, the extremely premature or the babies with complications of birth. It occurs acutely, in other words, everything has been going on fine in the pregnancy of the woman who suddenly ruptures her membranes or goes into labor at 23 weeks gestation. So things change very rapidly. The parents in that situation have almost no time to come to terms with what's going on because it happens so quickly. And similarly, if you're in labor at term and everything is going fine, and then suddenly the fetal heart starts dropping and people start yelling and running around and saying we need an emergency cesarean section, you've only a matter of minutes to decide as a parent what is going to happen to the baby after the baby is born. So these issues involve both the pregnancy in and of itself and the baby. By contrast, later death in newborns, so babies who die after weeks and weeks and weeks or months and months and months, can happen sometimes in the first two groups, but it's less likely. It's much more likely in the group where the multiple abnormalities intrinsically in the baby are causing life-supporting problems, either individually or collectively. And this is very different because today, the vast majority of women have prenatal diagnosis. So the vast majority of babies with major abnormalities have been diagnosed weeks or months before the birth. And so a plan is made based on what the findings are, and I've listed all of the various organ systems there that can be diagnosed in great detail on prenatal, ultrasound, MRI, or genetic blood tests or other tests. So usually what happens is there is then a discussion based on the anomalies, and in the majority of cases of severe anomalies, the parent or parents would decide on termination of pregnancy. In a minority, the pregnancy will continue. And then, interestingly, the fetus becomes the entire focus of the ongoing pregnancy. And there's an interesting debate in ethics, and my philosophy colleagues love this kind of debate, as to whether we now have one or two patients. So has the mother been now reduced to the status of a vessel or an incubator, and the real patient is in her womb, because that's where all of the attention, and actually that's where all of the action is. And so the rest of the pregnancy, the duration of the pregnancy, where the mother gives birth, whether she has a cesarean section or not, etc., will all be planned on the basis of fetal well-being. To the point, for example, where if you have a baby with complex congenital heart disease and you're living in Peace River, you will be transferred down at around a week or two before your due date in order that you will go into labor and give birth to your baby in Edmonton and not in Peace River, because that baby will need intensive life support at birth. And so the decision, obviously with the mother's consent, will be made to have the baby not in your hometown, but in Edmonton or elsewhere. So I emphasize this because this is a plan that's already up and running long before this baby is close to being born. And so when these babies with these kind of conditions are born, the parental expectations and their understanding of what is actually going on have been hugely influenced by many, many detailed conversations with multiple subspecialists about all kinds of esoteric details of what's going on with the baby. The NICU staff, for the most part, meet these families as strangers. And so it's really important to understand that there's an entire history, an entire narrative that's gone on to which we haven't been party at all. As I said earlier, the majority of deaths of critically ill infants occur soon after birth, so a matter of hours, days, or occasionally weeks. However, there is a significant minority, because of our ability to use life-supporting treatment, who will remain alive in a somewhat debilitated state for a much longer period of time. And the longer that you're on life-sustaining treatment, or certainly aggressive life-supporting treatment, the more complex that treatment gets, and of course the more likely complications of complications are to occur. So as I've listed here, ECMO, which is a sort of bypass system, dialysis, which is obviously something most of you are familiar with for kidney failure, tracheostomy, where you have to put a tube in the airway for weeks or months. These things all are part and parcel of continuing life-supporting treatment. And then we get to the stage of failure. And failure can either be very sudden and dramatic and result in the death of the infant, or it can be gradual. There's a gradual increase in complications. The kind of treatments we're working just seem to be less and less effective over days or weeks or months. We're gradually increasing multiple kinds of support of life and yet not getting any significant improvement. And in those situations, that's where the so-called end-of-life discussion occurs. And it's not really an end-of-life discussion. It's a discussion about where are we going and what are we doing at this point and what are the goals of what we're doing. So it's ideas around trying to clarify what the family understands is happening, what the healthcare team understands is happening, and what maybe other folks who may be helpful would explain what's happening. So in the past, this would have been a very traditional, very one-sided, somewhat paternalistic discussion between the attending physician, the charge nurse, and the parents. Today, it's a much broader, hopefully less paternalistic, and hopefully more productive discussion, which includes ethics, pastoral care, folks from palliative care, often extended family or other intimates, social workers, and last but not least, my esteemed colleague has departed, lawyers, who we would always try and keep out of the discussion for as long as possible. And the other thing which, being a dinosaur, I did almost forget about, but I remembered to put it in there, is that social media, of course, today will continue to play, I think, an increasing role in all of these discussions, both wanted and unwanted. We've a history of several cases in this jurisdiction over the past 5 to 10 years where there was massive publicity and massive social media reaction after the family went public about the kinds of discussions I'm talking about. So one of the difficulties around what the previous speaker spoke about was you can try and develop protocols and you can try and develop safeguards and you can try and develop all kinds of ways of trying to ensure that the vulnerable are protected, and yet at the same time not force them into a situation where you're actually practicing a kind of reverse discrimination. So in our need to continually protect them, we actually condemn them to a life of pain and suffering or debilitation or whatever that we would as adults find unacceptable for ourselves. And so there is that tension between trying to protect and yet at the same time not exposing them to unnecessary prolonged suffering or pain, etc. So the way to, I think, ensure that this should never happen optimally is to use palliative care. And that's another huge topic about what good palliative care is, etc., etc. But let's assume, for the sake of argument, that in the majority of infants, certainly, and youngsters probably, with optimal palliative care, the degree of pain and suffering that they must endure should be minimal. The other thing that optimal palliative care does is it helps us shift from thinking about the patient's condition in terms of survival and start thinking about it in terms of quality of life and comfort and all of the things that become important when survival is no longer possible. And so one of the problems in newborn ICU, and I suspect in other ICU settings as well, is that we tend to only involve palliative care as an end-of-life discussion, as an end-of-life option, whereas many palliative care physicians are extremely skilled in assisting with control of pain and suffering long before you're getting into a specific end-of-life problem. One of the reasons why dying in newborns is distinctly different from patients in older age groups is that the newborn in general, although incredibly resilient, if treated well in terms of life-supporting treatment, once there is a degree of damage to the brain in general, or to the central nervous system in general, and specifically to the brain stem, the degree of swelling there is pretty much fatal very quickly as soon as any kind of life support is withdrawn. And by that I mean specific life support, like a tube in the airway and medications to help with blood pressure and heart rate, etc. So when you physically take the baby off life support, it's very likely in the majority of cases that that baby will die within a matter of minutes, hours, or days. And because of this, there is often distress and certainly extreme discomfort about this whole issue of causation. And lawyers are very clear on causation. And I think doctors are very, in general, unclear about causation. So we associate A plus B in many situations, and there may be multiple associations, and we may come up with all kinds of clinical ways of looking at things, and we're very good at pulling information in from multiple sources and saying the end result of all this is you've got specific illness A, B, C, whatever. But we're not very good at doing the connections between things which seem to be causative when we're uncomfortable about that. This debate about whether there is a difference between allowing a patient to die of an underlying illness or hastening that death with sedatives or painkillers or whatever, whereby the purpose of what you're doing is to alleviate the suffering of the patient primarily, but it may also, and in the full knowledge of the practitioner, result in the patient not breathing anymore. And the classic example of that, as you all know now, because of the opioid epidemic in our society, is that if you use opioids to control somebody's pain, if you increase the dose sufficiently, they will stop breathing. And so you get into this very thorny argument about whether the primary purpose of increasing those opioids is solely to alleviate the pain and suffering of the patient, or whether it's in the full knowledge, and therefore maybe not solely, to cause the patient to stop breathing. My philosophical colleagues and ethics colleagues love this debate. And it even has a name, the traditional approach, and certainly the major religious supported approach is that if your primary purpose is to alleviate the suffering, then by the so-called doctrine of double effect, you're not culpable if the patient dies. One of the difficulties of that is if you're in my position where you're the guy who actually pulls out the endotracheal tube from the baby's airway and disconnects all the monitors and stops all the blood pressure medication, and you bring the baby in and hand her over to the parents, and they thank you because you've been through this dreadful journey already, and she passes away 25 minutes later, it's difficult for me to not worry or accept the fact that there is a connection there and that I was the trigger that caused that connection. One of the difficulties in the group of patients who linger on life support for weeks or months is that the NICU team have invested an extraordinary amount of blood, sweat, and tears into the survival of these particular infants. And so they may not recognize, because they've so much invested, both professionally and emotionally, that the baby is actually dying. And if you brought in a physician with expertise from outside of that environment and presented the case to that person, they would in many cases say, this baby's dying. But that's part of what goes on in the real world. And the parents will also go along with that for the most part. It's very rare for parents to initiate a discussion along the lines of, where are we going and what are we doing here? And are you guys sure my baby can still survive? It really is the job of the healthcare team to initiate that discussion. And as the previous speaker described, the standard approach in that situation where we recognize that the baby is dying is that we will then withdraw life support, because nobody wants a baby to die on the machines. And it's possible for a baby to die on the machines, but it will take much longer. And in general, we would think that most of us, if given the option, would prefer not to die on a breathing machine and on a whole bunch of intravenous medications, rather than being given the option of taking off that machine and to die in the company of our loved ones. And so that would be our general approach, and it would be a pretty aggressive approach once it's clear that the prognosis is the patient is dying. I'm not going to talk about the Dutch protocol, because I think it's been alluded to already. One of the great difficulties around it, and the group that was described in the New England reference have done many subsequent studies, and many of those studies are very disturbing, because what they've shown is that despite the fact that it's illegal, and despite the fact that the Dutch government has kind of built this system where they're scrutinizing the protocol and they're not willing to prosecute anybody who follows the protocol, there are all kinds of aberrations with the protocol which also haven't been followed up or prosecuted. So, for example, our current standard practice in taking babies off life support who may be still breathing actively is that we would give them a dose of opioid, of morphine or fentanyl, intravenously to ease their respiratory distress, not to stop them breathing completely, but to ease that respiratory distress. That would be pretty standard as an approach. But it's been described by the researchers who are in Groningen and who are subsequently researching the protocol that many Dutch neonatologists, in addition to doing that, would also give the babies a dose of a paralyzing medication. Now, clearly, if you give somebody a paralyzing medication, they can't breathe. And so the reason justifying this has been that they want to stop the gasping kind of breathing, which is terminal in most of us, because you have a very primitive brainstem which starts trying to help you to breathe, even as you're very close to the end of your life. And so the justification is to stop this terrible gasping type of breathing because it's distressing the parents. And so then you're getting into very murky territory about whose interests you're actually trying to protect here right at the end of life. Even though the end of life is pretty certain, there's a big worry there for me in that kind of thinking. Even though I've described situations that some of you might say, well, I would see assistance in dying as being appropriate for consideration for some of these infants, I think that kind of worry is something that lingers and we need to be extremely careful about before we would even consider approaching this. Thanks very much.
Our next presenter is Dr. Lester Liao. Dr. Lester Liao is a pediatric resident at the University of Alberta. Currently, he is a resident affiliate of the Dossiter Health Ethics Center and acts as resident lead for the Arts and Humanities in Health and Medicine program. Prior to medicine, he completed a master's in theological studies. His current research focuses on the philosophical and cultural underpinnings of medicine and ethics. His presentation title is How Worldviews Shape Our Understanding of Suffering and Disability and Quality of Life. Please welcome Dr. Liao.
I'm really glad that we're having this conversation. Increasingly, I think we see in our society, particularly when you look in the realm of political discourse, it's just totally breaking down. People are no longer able to appreciate that people have different perspectives and able to adopt different ways about thinking about things. We're kind of pigeonholed into the way we think about things, and it's actually destroying the way we can talk about these issues. So having this symposium, I think, is a great step forward. I think I'm going to take a bit of a different approach in how we can think about ending life at its beginning. And I want us to take several step backs and think about what are the kinds of assumptions that we need to make that will make us think that ending life at its beginning is either a good or a bad thing. I want us to have that open mind, because a lot of us will actually have emotional responses to this topic. And most people in this room probably already have an idea about whether they think it's a good or a bad thing to end life at its beginning. Maybe this will come out a little bit more when we have our discussion, but I want us to keep that in mind, that hopefully we can have some sort of civil discussion about this. Now, the other thing is we need to avoid mischaracterizing what other people think. Virtually everybody I've talked to about this issue has a good intention, whether they want to end life at its beginning because they want to end suffering, or whether they think life inherently has value and so we shouldn't be ending life. People have good intentions when they go about this conversation, so it's not really helpful to call someone a baby killer or to come around and say, oh, you just want this baby to suffer. Okay, that's not helpful. But we also know that good intentions aren't enough, because many of the things that have happened in the 20th century were done in the name of good intentions, utopias or whatever, progress, and millions of people died. We need to be careful that we don't mischaracterize people, but at the same time scrutinize what our intentions can actually lead to. Now, one of the important things that we need to do is we have to recognize that this is actually not a scientific question. This is a question about ethics. So what science does, or when you use the scientific method and empirical method, you observe stuff, you measure stuff. I say that these chairs are green. You can't tell me whether or not that is a good or bad thing. For you to tell me that these chairs being green is a good thing, you have to have a normative framework. You have to have something that says green is good. You can't get that from science. You can get that from being part of the University of Alberta, and our colors are green and yellow, and you say, oh, that's great. Okay? But if you came from another school, you wouldn't think that that's great. Right? So you need a normative framework, and that's where the question of ethics comes in. Ethics as a discipline is concerned with what is good, what is of value. Everything that we are going to talk about depends on the presuppositions that you make about what is good or what is bad. The question of neonatal euthanasia is a very, very downstream question. And so today I want to talk about the questions that lead to that question. Now, there are various ways that people think about approaches to ethics, and you can call these frameworks of normative ethics. And there are three big schools that people like to think about today. One is consequentialism. So when you're thinking about the scenario at hand, what makes an action right or wrong is the consequence. So if you are a consequentialist, you actually don't really care about the doctrine of double effect, because you're focused on what happens, not so much on the act itself. You don't have a kind of framework for evaluating intention. It's about what happens at the end. Another theory that's enjoyed kind of a bit of a rebirth or renaissance is virtue theory, which is classically associated with Aristotle. And virtue theory focuses not so much on the act, not so much on the consequence, but on the moral character, on the kind of person that is doing this and what kind of character are we fostering. And then finally, you have deontology, which is focused on the rules. Something is either right or wrong to do because the act itself is right or wrong to do. This picture, I think, communicates something that's very fundamental to all of us. You're out on a starry night, you're looking up at the sky, it's beautiful, and you're thinking to yourself, what is this? What does all of this mean? The fundamental approach you have to answering the most basic questions about life, where did I come from? Where am I going? What's the purpose of life? How should I live? These are things that are a reflection of what I call your worldview. And this is a term that's widely used. Worldviews are that fundamental set of commitments that we have that you will have a hard time trying to articulate exactly how it comes about. How you answer those four questions is going to completely influence the way you answer the question of whether or not neonatal euthanasia is a good thing. And the fourth question, how should I live? That's the last portion of a worldview, is the question of ethics, is the question of that we're going to apply to neonatal euthanasia. But how you think you should live is going to depend on what you think a life should be. And it's going to depend on whether or not you think this is the only life, there's a life afterwards, there's a God, there's not a God, these religions are true, these religions are not true. All those kinds of things will fundamentally impact how you think. I want to read you this one quote from Michael Sandel. He's a philosopher at Harvard. He says, "To achieve a just society, we have to reason together about the meaning of the good life and to create a public culture hospitable to the disagreements that will inevitably arise. We live in a pluralistic society. People don't think the same way. Because we live in that kind of society, we have to be civil about our discourse, and we have to recognize that people have differing fundamental presuppositions, and how can we go about talking about them?" As I said, bioethics is very downstream, okay? And there are all sorts of things that impact how you think about bioethics, and specifically the question of neonatal euthanasia. You have on there the three classic kind of divisions of philosophy. You have epistemology, the question of how do I know what I know? How can I come to a knowledge of what that good thing is? What is good would be a question of metaphysics. So ontology, what is real? What actually exists? Does good exist? And then how do I know whether or not, or how do I come to a knowledge of that good? Is it based on my reason? Is it based on my feelings? And then axiology is the question of value. And those are the three kind of areas of philosophy that will drive how you understand bioethics. Another part that's really important for us to consider is sociology. You and I live in a very particular time, and we have very particular influences around us, and the more you read kind of in sociology or in history, you begin to see that. So sociology and history both are really important in helping us understand why we tend to believe what we believe. And then finally, psychology, our own inner understanding of the human person, so on and so forth. This kind of sounds like this theoretical discussion, and it's kind of up in the clouds, but I want us to think about how this affects reality. So does anybody know which famous philosopher said this quote? "Life is so unnerving for a servant who's not serving. He's not whole without a soul to wait upon." Somebody shout it out. Lumiere, exactly. So Lumiere is actually a philosopher, okay? Everybody in this room philosophizes in some way or another. But what Lumiere is saying here, okay, he's actually adopting what I'd call an Aristotelian framework of how a good life should be lived. He's talking to Cogsworth, it's Be Our Guest, Belle is there, and Cogsworth is just not enjoying the party. And Lumiere says to him, look, you're a servant. That's kind of your role, that's your design in this scenario. And the way you are actually going to live the good life, how you're going to be happy, is if you actually fulfill your role. Okay? And then, of course, you see Cogsworth slowly gets into it, and then he starts dancing, and he has a great time at the end when he's become part of the celebration. This is not a very popular way that we think about ethics today, but it is one that exists, okay? And one that's important for us to think about. Another famous philosopher. "I know everybody on this island has a role on this island, so maybe I can roll with mine. I can lead with pride. I can make us strong. I'll be satisfied if I play along. But the voice inside sings a different song. What is wrong with me?" Anybody? Moana, exactly. It's so recent, so people know this one. I mean, part of the reason I'm pulling up these examples is because sometimes when people talk about philosophy, you're like, that's just, it's in the clouds, it's in an ivory tower, it's just, a bunch of people just talking about random stuff. But these philosophies actually make their way into day-to-day life, and they make their way into popular culture. Kids watch this stuff, and they adopt certain kinds of mindsets. What's happening here is you actually have Moana having a conflict, right? I'm going to analyze Moana for you. She has this sense that she has a duty. There's a kind of deontological sense. There's a duty. There's something she's supposed to do. And yet at the same time, she has these feelings. She has this inner longing in her being that she should be doing something else. And the two of those things are conflicting. Because we live in the society we live in, we tend to side with the idea that she should follow her feelings. She needs to be true to herself. Right? That is what I'll describe as a sort of existential framework for approaching how we make decisions. And then one more. This one's not from a song. It might be hard to recognize. "I needed to get out on my own, live my own life, and I did, and it's great. Why worry?" And then the response is, "Because it's your responsibility. Don't you understand? You're our only hope." If you can guess from the themes, you might be able to guess where this is from. Anybody? Oh, wow, a lot of people know. Nice. So it's Lion King. So what's going on in this scenario? Simba has left Pride Rock. And at this point, the people don't know why he's left Pride Rock, but he's with Timon and Pumbaa. He's eating slugs. He's having a great time. And he's saying here, he's actually kind of sharing this existential idea. Well, actually, I needed to follow my own feelings. I needed to live my own life and enjoy it. And I'm having a great time. Why should I worry about this? And then on the flip side, you have Nala say, well, actually, it's your responsibility. Okay, you're the future king. You need to come back. So this is different from the Moana example. And Moana has the duty, and she's going with her feelings. And Simba initially goes with his feelings, and then he has his duty come up, and then you have forgotten who you are, you must take your place. Mufasa, boom, epic scene, right? Comes out in the clouds, and he tells him, you need to go back to Pride Rock. Now this is interesting because I want to also help you think about how you encounter these things when you watch movies. You encounter these philosophical paradigms day to day, and they're going to influence the way you think about the question of neonatal euthanasia. It sounds like I'm talking about really distant stuff, but at the end of the day, this is embedded in your mind, and it trickles down into how you think about neonatal euthanasia. How do we think about things today? This is broad, okay? And I'm not saying that all people necessarily think like this. What I want to do is I want to trace the history behind some of the ideas that we have, help us understand why we may hold the perspectives that we hold. Generally, in Western academia, approach to ethics, we generally apply to three principles: secularism, individualism, and existentialism. We don't necessarily do those consciously, but I think those are three important ones. And I'm going to focus mainly on existentialism. The other thing that's important for us to recognize is Jonathan Haidt, who's a social psychologist at NYU, he talks a lot about why we kind of have moral divides. And one of the things that he points out is that we are a particular sociological group. We're weird. We're Western, educated, industrialized, rich, and democratic. Weird people approach questions of morality differently from non-weird people, okay? And one of the reasons that that becomes more obvious to me is because I'm from Taiwan, right? And the culture there is different, so we don't necessarily think about questions in the same way. I want to trace a really quick history of existentialism and like the history of philosophy in like 5 minutes. In the beginning, you had the Greek worldview. The first philosophers, you had the cosmos, and you had the Stoics and Aristotle. And the Stoics believed that the world was divine and orderly. Okay, so they believed that actually, what was philosophy? Philosophy was this pursuit of wisdom. It was about me contemplating the world. You would go out, you would observe the sky, and you would say, this is a wonderful thing. And so how am I going to live the good life? I'm going to conform myself to this reality, because this reality is divine. It's good. And so that's where my sense of like the right thing to do comes from. I'll read this quote from Cicero. "Nothing is more perfect than this world, which is an animate being endowed with awareness, intelligence, and reason." If you buy into that worldview, if you buy into the idea that the world is divine and that it's ordered and structured, that's going to impact the way you think about interventions that you kind of make in life. But in that worldview, conformity to that was what was described as perfect and beautiful. And Aristotle specifically had a very high notion of telos, or design. How you also began to understand whether or not something was good was according to design. How do you evaluate whether like a hammer is a good hammer? Well, what's the purpose of the hammer? A hammer is probably really bad at measuring temperature, but it's really good at hammering in nails. So a good hammer has to hammer in nails. Whether or not it can tell you what the temperature is kind of an irrelevant criteria for whether it's a good hammer or not. After you had the Greek cosmos, you had the Christian kind of revolution. And what happened in the Christian worldview is you had a similar sense in divinity. But now divinity was not this vague thing in the world. Divinity was actually ascribed to a personal God. And this personal God had kind of the attributes of that divine space. So now God becomes the one who is all-knowing, good, so on and so forth. And he's the one that organizes the universe. You also continue to have the concept of telos, or design. If God created us, then God has created us with particular capabilities, so on and so forth. And so the good life becomes one in which I'm able to follow my design as I was created by God. And you and I can think of this in the same way, again, when we're creating things, you have to follow the design or the instruction manual, so to speak, of an item for it to flourish. So using a car, you don't put orange juice in the tank, you put in gasoline. How do you know that? Well, you read the instruction manual and it'll tell you don't put orange juice in there. You have an idea, you have to, for the car to flourish, for the car to function as it was intended to function, you have to use it according to its design. The major thing that changed with the Christian worldview as opposed to the Greek worldview is that you had the idea of the image of God come into play. And the image of God was this idea that God has actually created people with intrinsic value. And what that did is it became a great equalizer, and the notions that we have inherited today, particularly in North America and the Judeo-Christian heritage, is the idea of equality. And that idea initiated, I think, in many ways with the Imago Dei. Morality, in this sense, is no longer ascribed to individual attributes that you have, but in your exercise of those attributes. Because we can't evaluate people according to their abilities to say whether or not their life is of value or not. They all have value. Everybody has value, equal value. But what becomes about the questions of right or wrong reflect what we do with those things, the exercise of our responsibilities, which was kind of a reflection of a rational God giving us rational capabilities. After the Christian worldview, you had the development of the Enlightenment. And the Enlightenment started with the kind of the Copernican and scientific revolution. And the scientific revolution changed the landscape in two major ways. Luc Ferry, who's a French philosopher, he describes these two consequences as such. One, man lost his place in the world. You have to understand that with the scientific revolution, it changed the entire way that people began to think about things. No longer is the world good and ordered. The world has become a chaotic place, and it's no longer a structured place. On top of that, it's hard for me now to understand what is my place in the world when the world has become this chaotic thing. And so there was a sort of intellectual crisis that occurred. The other thing that Luc Ferry says is that the cosmos itself, remember, the enclosed harmonious frame of human existence since antiquity, quite simply evaporated. People are confused now about how to think about reality. I'll read this one stanza from a poem by John Donne. One of the places where you can really see how people are struggling with the ideas of philosophy. You see it trickle down in literature and so on and so forth, and I guess in Moana. New philosophy calls all in doubt. The element of fire is quite put out. The sun is lost, and the earth, and no man's wit can well direct him where to look for it. 'Tis all in pieces, all coherence gone, all just supply, and all relation, to make it rhyme. This was the crisis that people were beginning to face. And so what you needed when the world lost all sense of coherence is you needed a new way to make sense of the world. And that's where Immanuel Kant came in. Immanuel Kant, historically people saw an objective reality, and subjects needed to interact with that objective reality, but we needed to gain our knowledge from that objective outside. And Immanuel Kant came along and he said, actually, the world is chaotic. And if the world is chaotic, how do you find structure? Structure doesn't come from the world, it comes from you. You and your mind impose that structure on the world. Other things that also began to happen generally in the Enlightenment is you had the rise of reason as sort of its own divine principle, human progress, so on and so forth. Now, moving a little bit closer to where we are today, you had one man who I think completely demolished so many of the ideas that came up in the Enlightenment, and that was Nietzsche. Nietzsche's entire project was to destroy Enlightenment ideals. He argued that the Enlightenment humanists who believed in progress, who still believed in all of these structured things, were still, in effect, theologically speaking, like they believed in God. They still were, in effect, believers. They still thought that there was such a thing as progress when the world was chaotic. And he said, well, that doesn't make any sense because there's no such thing as moving forward or moving backwards because there's no metric by which to measure that. He says in Ecce Homo, to overthrow idols, his word for ideals, that rather is my business. Reality has lost its value, its meaning, its veracity, and an ideal world has been fabricated to take its place. Nietzsche was the first real deconstructionist, and he argued that none of this really makes sense if we actually buy into this metaphysical notion that there is nothing divine and this chaotic world is all that we have. And he also was a suspicious guy. He believed that people putting forward their ideals of progress, so on and so forth, were actually hiding wicked intentions underneath that. And instead, he posited this idea of eternal recurrence. The important way to live is actually to live your life in such a way that you would live it the same way all over again. And that became his criterion for deciding whether or not there were certain moments in life that were worth living or not. No regret, no remorse. Nietzsche is the father of YOLO. Okay, he's the father of the way we think about how we live today. Now, a little bit before Nietzsche, and he drew from these ideas, is with the Enlightenment, you had the counter-Enlightenment and the rise of Romanticism. And here I draw heavily from the work of Isaiah Berlin. The entire Western tradition was based on the idea that virtue is knowledge. Okay? If you know the right things, if you study the world, you know the right things, and you do those things, you can live the good life. What that knowledge necessarily was, people disagreed about, but people agreed with the premise that you need to know certain things and live out those certain things to live the good life. The view is that of a jigsaw puzzle of which we must fit in the fragments of a secret treasure we seek. All right, so that includes questions of science and in the Christian and Greek worldviews. Because what is science? Science is describing phenomena out in the world that we can apply to live well. And then there was a big transition, and MacIntyre describes kind of a framework. MacIntyre is a moral philosopher. He describes a three kind of point scheme. He says, you have untutored human nature, you have man as he could be if he realized his telos or design, and you have three, the moral precepts which enable him to pass from one state to the other. That has changed with Romanticism. And there were two key ideas. Romanticism was a movement that grew out of Germany and had influential other thinkers like Rousseau. But what Romanticism was dissatisfied with this kind of sterile reason. And Romanticism, taking into account that things have changed, argued for the importance of the will. And I think in many ways, Immanuel Kant, even though he was kind of a champion for reason, was actually the father in many ways of Romanticism. You are the one that creates values, okay? There's no values out there for you to find and to live according to. You create values, you create goals, and you create the ends for which you must live. There is no structure to the world, and there's only the endless flow of creativity. And that leads to modern-day existentialism. Modern-day existentialism is I think Nietzsche, you can argue that he was maybe also the first existentialist, but Existentialism is the idea that you exist. Existentialism, right? Anytime you take an ism, humanism, whatever precedes it is that kind of central principle about what's real and what's good in the world. Existentialism is the idea that what's most important is the fact that you exist. There's no such thing as essence. There's no human nature. It's just the fact that you exist. The French philosopher Jean-Paul Sartre was very influential in disseminating these kinds of ideas because he was a philosopher in his own right, but he also wrote kind of more popular literature. He says, man exists, turns up, appears on the scene, and only afterwards defines himself. If the world is chaotic, you have to define all these things for yourself. And no longer is there a goal for you to move towards. You have to create that goal for yourself. And so life begins to consist of creation. It consists of your personal experiences and the expression that you have of those experiences. The two other things, there's secularism and individualism. They kind of fit in with the rise of existentialism. Secularism, I'll just say quickly, there's two ways to think about secularism. One, you can think about it as a sociological phenomenon. You know, historically, sociologists in the 60s thought that as the world becomes more modern, it necessarily becomes more secular. But one of the prominent sociologists who recently passed away revised that thesis in 1999. His name was Peter Berger. He realized actually the world is actually becoming more religious, and we're actually becoming pluralistic, not necessarily secular. And anybody interested in this, and I'll refer to him a little bit more, is Charles Taylor has written a book called The Secular Age. It's a beast of a book, but he was a prominent Canadian philosopher that looked at how we got to this place where we are secular today. And then finally with individualism. Individualism has risen because of economic and technological reasons, right? You all have your own phones, right? When you want to watch something, you watch your own Netflix. You don't sit around with 5 other people and your fam and decide what we're going to watch on the TV together. It's like, no, I don't want to watch that. I'll watch Netflix, on my own. Technology has vastly influenced the way that we think about what our options are. We tend to think of things that are catered towards ourselves. Individualism also as an ideology kind of developed, again, specifically actually you had in the Christian worldview with the image of God. Everybody individually now had kind of a say. It was important. And then with the Reformation, you had Martin Luther come along, and he said that faith was an individual matter. It's a matter of between you and God, and you can have access to God yourself, not necessarily mediated in the same way through the church, but that placed a huge emphasis on the individual. So on and so forth with the development of enlightenment, reason, and so on. But what does all of that have to do with neonatal euthanasia? If you buy into the existential framework, if you buy into the existential worldview, that's going to change the way you think about what it's like and what the experience is like to live as a disabled person. A lot of what I've said has been kind of theoretical, but I want us to think about it in an embodied sort of way. What does that actually mean on the ground? Most of you in this room can understand this existential ideology, and many of you can understand it because you speak like an existentialist, even though you don't necessarily think of yourself as an existentialist. So, for example, YOLO, right? You only live once, you got to do all this stuff, right? You need to follow your heart, you need to be like Moana, right? These are all kind of things that have flown from the existential sort of worldview. Now, what does that look like on the ground? If life is about yourself, life becomes about self-actualization. It's about you being the best person you can be. And again, when I say that kind of stuff, many of you are like, oh yeah, we hear that all the time. Institutions, social relationships, whether that's marriage, family, school, so on and so forth, become about you. What can family do for me as opposed to what I can do for family? And because all you have, you don't have divine principles to rely on. All you have is you. That changes the way you think about freedom. When I say freedom, most of you think about freedom as having no restrictions. People historically have thought about freedom not just in terms of restrictions, but in terms of the things that I can do. In the existential worldview, autonomy becomes the highest good because you are the only thing that exists. You have to create your own laws. Disabled people can't necessarily do that in the same way. If you think life consists in intensity of experience, and disabled people can't have those kinds of experiences, then that life is no longer a life worth living. Your existential framework will impact how you understand disabled people, people that are suffering, so on and so forth. It's the intensity, right? If you can't self-actualize, what else is there? There's nothing else. It's chaos. It's meaningless. Some of you, though, will be dissatisfied with the existential worldview. You don't think the world is completely chaotic. You have what Charles Taylor calls the haunting of transcendence. There's got to be something more out there, and that's why I think you see the rise of New Age spirituality in the world today, specifically in places that historically have been the most secular. So specifically in Quebec and places like France, you see the rise of New Age spirituality. People want to believe in something greater. They don't want to believe in kind of the the imminent frame, as Charles Taylor calls it, that things were just restricted to this. You feel that haunting sense that there might be more. And if you have that kind of worldview, and I would say the Greeks kind of fit in this, pantheists, nature becomes a divine thing, it's a good thing, and it changes the way you think about whether or not you should intervene for a neonate. Rousseau believed that nature was a kind of a good thing, and that actually impacted the way he thought about whether or not you should use vaccines. It impacted the way that he thought about whether or not you should use medicine. If you believe in karma, right, and you believe people get what you deserve, in certain parts of the world, if you have a disabled life, it's because you did something bad in your old life. And so that changes the way I think I should intervene to help you or not. Historically, the Greeks practiced infanticide, right? There's certain things about what you believe in the universe that's going to impact how you approach things. Or you feel an even greater sense of that kind of transcendence and that haunting, and you find that kind of nebulous spirituality kind of weird. You see personality and love in the world, and you think that the best way to understand it is to believe that there's a divine creator, and that would be the Judeo-Christian worldview, right? There's kind of a dissatisfaction with the materialistic reductionism. And in the Judeo-Christian worldview, all people are created equal, and they're all endowed with value. That's going to change the way you interact and say whether or not I can end somebody's life, because life is not necessarily a matter of experience. Life has inherent value. I'll read this little quote to you from Bonhoeffer. He was a neo-Orthodox theologian and martyr at the time of Nazi Germany, and he actually attempted to kill Hitler. He said, "This so-called worthless life of the incurably ill has elicited the greatest amount of social readiness for sacrifice and true heroism among the healthy. Values of the highest real utility for the community have emerged precisely from such dedication of healthy life to sick life." That may not be something that you find very interesting. On the other hand, you may see, actually, that's how you create a sort of society in which we really care for one another. But if life is about you and your self-actualization, why do you need to care about those sorts of things? At the end of the day, every single person comes to this issue with a worldview. All I've tried to do, and kind of very broad sweeps, is talk about what those kinds of worldviews can look like and how they make us think about neonatal euthanasia. These aren't the only ways these worldviews work out, by no means, but they give us a flavor. They give us a sense of how the things that you read about and think about day to day will actually impact the way you think about neonatal euthanasia in a way that maybe you haven't thought about before. So what you actually need to think about, rather than surely the question of suffering, is you need to think about, well, what makes a life worth living? What kind of assumptions do I need to buy into to make me think about that? I'll finish with this final quote from Michael Sandel. "Debates about justice and rights are often unavoidably debates about the purpose of social institutions, the goods they allocate, and the virtues they honor and reward. Despite our best attempts to make law neutral on such questions, it may not be possible to say what's just without arguing about the nature of the good life." The good life is what makes you think about neonatal euthanasia, okay? Existentialism will give you a different answer. The Christian worldview will give you a different answer. And so hopefully, later in the panel, so on and so forth, we can talk about the undergirding of those worldviews, what makes the most sense, and how we should think about neonatal euthanasia. Thanks.
Our next presenter is Dr. Howard Nye. He is an associate professor of philosophy at the University of Alberta, and he works primarily in areas of normative ethics, practical ethics, and meta-ethics, and has related interests in political philosophy, the philosophy of mind, and decision theory. His recent publications include Well-Being, Self-Regarding Reasons and Morality, Non-Consequentialism Demystified, Directly Plausible Principles, The Wrong Kind of Reasons. Much of Howard's current research investigates challenges to the common assumption that life is less of a morally important benefit to beings who lack the intellectual abilities of typical human adults. I would also like to mention that Dr. Nye is the faculty lead for planning this symposium, and his presentation title is Why Death is a Serious Harm to Neonates with Severe Intellectual Disabilities. So please join me in welcoming Dr. Howard Nye.
Thanks so much, Kendall. Having had Lester warm you up to the idea that these are ethical issues that depend very much on issues about what's good and bad and things of that nature, I'm going to try to give an argument against certain kind of neonatal euthanasia, against those with severe intellectual disabilities, that I hope will be able to find compelling ground regardless of your initial starting points. Dominic Wilkinson reports that in his experience of neonatal and pediatric intensive care, the single most important factor in discussions on the withdrawal of treatment, I think he means from infants who otherwise could definitely live and survive and be released from the NICU, is the presence or predicted presence of severe intellectual disability. So by severe intellectual disabilities, I mean having an IQ of between 20 and 34, having conceptual abilities similar to typical 3 to 6 year olds, and having limited symbolic communication, and usually needing close support throughout life. And when I talk about severe intellectual disability, I mean actually to include individuals with profound intellectual disabilities as well. So that's understood as having an IQ of less than 20, having conceptual abilities similar to typical neonates to 3-year-olds, and having communicative abilities that are mostly non-symbolic or non-compositional linguistic, and being able to achieve some basic self-care with learning, but requiring very close support throughout life. And when I talk about severely intellectually disabled neonates, I'm focusing on clearly sentient neonates who definitely can experience the world and feel pleasure and pain. So I'm not, for example, talking about anencephalic neonates. I think they raise special issues, which we could talk about in Q&A if you want, but I'm talking about clearly sentient, severely intellectually, and profoundly intellectually disabled neonates. What I mean by selective non-treatment is not giving someone life-saving treatment in circumstances in which we would treat others on the grounds that she or someone else does not have as strong of an interest in her survival. And it currently seems that selective non-treatment on grounds that a neonate is severely or profoundly intellectually disabled is legal and not at all uncommon in many jurisdictions. So Andrew Pinter, in reporting some guidelines that I think he takes to codify best practice in 2008, says that for group 5 neonates who are severely mentally affected, after birth treatment is justified only on strong parental wish, apparently because, in the physician's views, of poor prognosis for a meaningful or reasonable quality of life. What I'll call the practice of selective euthanasia is actively ending someone's life with the intention of doing so in circumstances in which we would not end the lives of others on the grounds that she or someone else does not have as strong of an interest in her survival. This is what's been decriminalized in the Netherlands, among other things, under the Groningen Protocol. For example, the Groningen Protocol talks about or tries to justify the practice in cases of extremely poor quality of life, i.e. suffering, in terms of functional disability, pain, discomfort, poor prognosis, and hopelessness. So one immediate conceptual confusion, I think, here is there seems to be a suggestion that functional disability is in and of itself a form of suffering, which I think is highly suspect, but it also seems to be the sort of idea that's underlying the current practices of selective non-treatment. Wayne Sumner, I think, makes an excellent point in his book on assisted death, which I would highly recommend to everyone, even if you disagree with his conclusions, that there's been something quite remarkable about the controversy over the Groningen Protocol, in that critics have focused almost exclusively on the criteria of poor quality of life and intractable suffering, as I mean to do. But what is novel in the protocol is the use of euthanasia for infants selected for non-treatment instead of waiting for them to die of their condition. And I agree with Sumner that this is sort of a strange thing, particularly because in practice, what the protocol seems to have done is primarily allowed the euthanasia of infants who otherwise would have needed treatment to survive and are thus susceptible to selective non-treatment in a jurisdiction like ours anyway. And there's been almost no euthanasia, actually, under the protocol. So Neil Francis in 2016 reports that of the 10 years it's been running from 2006 to 2016, there had only been 2 cases of euthanasia under the protocol, in cases of severe dermolysis bullosa, that's the blistering skin condition that causes a lot of pain. Before that, actually, there had been more active euthanasia, even though it was illegal. Estimated 22 cases per year, all of which did involve in the past disability. Francis talks about possible reasons for this. First, there was a change in policy regarding the neuromuscular blockers that Paul talked about being so worrisome, in that the Netherlands seems to have cracked down on that, and so now doctors aren't doing that anymore. Fewer also believe that opioids in appropriate doses actually hasten death. There's also been improved folic acid supplementation, which decreases neural tube defects, which decreases cases of intellectual disability, and also increased prenatal screening and selective abortion for parents who don't want to have a severely intellectually disabled child. I agree with Sumner that there's something odd about criticizing Groningen for selective euthanasia, but being fine with our current practices of selective non-treatment. But that's fine, because I intend to be an equal opportunity criticizer. So my thesis is that death is actually a serious harm to neonates with severe intellectual disabilities, and this gives us powerful moral reasons not to deliberately end or omit preserving their lives when they can survive. And these powerful moral reasons oppose selective euthanasia and selective non-treatment of neonates with severe intellectual disabilities. So I'm going to defend my argument against sort of what I take to be the strongest argument for the opposite conclusion, the standard argument in favor of selective non-treatment and euthanasia. So I think this argument goes like this. in very broad outlines. So first, death's harm matters. The strength of our moral reasons to preserve or omit ending someone's life, at least if she can't give competent informed consent, is determined by the extent to which death harms her. So there are powerful moral reasons to preserve or omit ending someone's life, just in case death will be a serious harm. So death doesn't seriously harm them. This is the thing I want to argue against. Death does not seriously harm severely intellectually disabled neonates. And it's concluded from that there are no powerful moral reasons to preserve or omit ending the lives of severely intellectually disabled neonates. So discomfort to them from life-saving treatment, cost to society of giving treatment, and cost to parents of caring for them can outweigh our reasons to preserve their lives. So I actually agree with this first premise. This argument, I think, is all of the big arguments in favor of selective non-treatment euthanasia, like those of Tooley, Singer, and McMahon, Wilkinson. So I think the argument's first premise that death's harm matters to our reasons of beneficence to preserve someone's life and our reasons of non-maleficence not to end it is actually quite correct. I think this is actually very clear in the case of reasons of beneficence to preserve life, and most of us very clearly accept it. So consider a triage type case, a stylized one. Suppose you can give life-saving treatment at time t0 to Alice, who will live 60 great years from t0 to c60, or to Beth, who's going to die in a few days anyway, right? She'll only live from t0 to t 0.0006. Obviously, in a case like this, stronger reasons of beneficence to save Alice decisively outweigh the radically weaker reasons to save Beth, because Alice has so much more to lose from dying at time t. Also with withdrawing treatment, right? So withdrawing treatment for individuals who will not benefit from continued existence. So not resuscitating those who we can be extremely confident are irreversibly comatose. Have to be very careful with whether they're actually irreversibly comatose, right? That's a very important ethical issue, but if you can be, right, nothing wrong with withdrawing treatment. And also not undertaking undertaking painful or costly surgery to keep alive those who we can be extremely confident will die extremely soon. I think it's more controversial that this is true with reasons of non-maleficence, but I think it's actually inescapably correct. Paul was hinting at a case like this. Consider withdrawing treatment, for example, ventilation. In my case, and I think the clear case where it's okay would be from the irreversibly comatose, perhaps to save several $1,000s or give the family closure by bringing about the biological death. I think it's fine, obviously, and I think we'd all agree it's okay to actively intentionally cause biological death here, because biological death actually isn't a harm if you're irreversibly comatose. Now, there's an objection here that Paul was sort of mentioning some people might make, that it isn't okay to intentionally end someone's life here because death isn't not because death isn't a harm, but because it's the underlying disease that kills her, not us. But I think this move about what's doing the killing is completely unacceptable, because this would not be an acceptable justification if it were someone who just needs temporary ventilation to go on to live 60 great years, but whose ventilation we removed in order to save a few $1,000s, or to give her family who find her difficult to deal with closure, even though we and the underlying disease would play identical roles in both cases. So I think it has to be death's harm. And then finally, I know this is a tough issue for some of you here, but to make it really clear, I think that intentional death, if death is not a harm, intentionally causing death, not a problem. The police officer's dilemma, right? So suppose in this fanciful scenario, someone's trapped in a car slowly and agonizingly burning to death. You know with 100% certainty that you can't get her out, and if nothing is done, she'll spend the next 30 minutes in complete agony that crowds out all mental states other than pure suffering, and she's begging you to shoot her in the head and end her suffering. In this case, you only have two choices: let her die after 30 minutes of the most intense agony possible with no compensating goods, or painlessly shoot her in the head now. I think pointless suffering is definitely a serious harm that we have strong duties to prevent. That's what actually underlies the moral urgency of palliative care in the first place, or just providing anesthesia during surgery and analgesics to anyone who needs them. Here, the prevention of the suffering requires shooting, and unlike, and I think any realistic real-world scenario, except maybe organ failure or something like that, there's no goods opposing it. I think that even opponents of assisted death in contexts like ours, where palliative analgesia and sedation are options, should be okay with assisted death in this admittedly fanciful scenario, and can use this to help see that, in fact, whether death is a harm really does matter to the ethics of killing. And I think you should also be okay with a version of this in which the victim's a neonate who can't give competent informed consent, who's trapped in the car, but who's wailing in pure agony. Truly awful, but in this fanciful scenario, I think you definitely have to intentionally cause the death of the neonate. And skepticism about whether that neonate is actually suffering here would be just as unjustified as refusing to provide analgesics to clearly suffering neonates on similar skeptical grounds. So I think that would, how do we know whether she's really having agonizing suffering? That's just an unacceptable cop-out. I do think that the first premise of this pro-selective euthanasia non-treatment argument is correct. So everything comes down to whether death, in fact, does seriously harm disabled neonates. So a popular argument that a lot of you may have heard for why death doesn't allegedly harm severely intellectually disabled, or indeed any neonates whatsoever, is the following, that Peter Singer's popularized. So it first starts with what we might call the current desire thwarting account of death's harm, that death per se harms individuals exclusively by thwarting their current desires about their futures, right? Like, you and I, we want to go on living, we have these hopes and dreams and ambitions, and by killing us and thwarting those ambitions, that's why death harms us, right? That's the idea. Second, it plausibly observes that no neonates can conceive of their futures or engage in future-directed planning, so so no neonates can have desires about their futures right now, and so it concludes no neonates are harmed by death. I actually think this is not a very persuasive argument at all. It's the decisive problem with it is that the first premise, the current desire thwarting account of death's harm, is just deeply implausible, and authors like Jeff McMahon, who have done a great job bringing out the implausibility. So individuals' desires can change over time, and they can fail to reflect what's best for them. It's arbitrary to privilege our current desires in this kind of way. Why should it matter whether someone currently desires her future if she'll enjoy and benefit from the goods it will involve when it comes? So we can illustrate this with various cases. For example, the current desire thwarting account entails that death can't harm suicidally depressed adults, even if they would recover and enjoy life if they survived. Or indeed teens whose only ambition for the future is to be rock stars, when we can be confident they won't in fact succeed in being rock stars. And in fact, they'll have like these wonderful lives with being postal carriers and having families, but they tell you absolutely sincerely right now, kill me now if I won't be a rock star and if I'll be a postal carrier. It's like, sorry, current desire thwarting account of death's harm, death would still be bad for them in those circumstances. Now, you could try to fix this by revising the account to say that what harms someone is what thwarts the desires she would have if she were fully informed and rational, but there's deep problems with that. So first, unless rational just means has all the desires for future goods one would have, that one would actually enjoy or benefit from, one could fail to desire futures from which one would benefit, and we'd still get the first problem. And if neonates were actually made fully informed and rational in the relevant sense, they actually could conceive of their futures, and they would desire those futures, and therefore on the revised view, they'd be harmed by death. Right? So I think this current desire thwarting account argument is just not gonna work. I think the problems with the current desire thwarting account reveal the plausibility of a rival account of death's harm, which I'll call and philosophers call the deprivation account of death's harm, that death harms individuals by depriving them of future goods, and it deprives and thus harms them to the extent that first, their futures would have contained goods, obviously. And second, and this is a little more tricky and philosophically, but to the extent that they would have persisted as individuals who would have experienced those goods. And there are actually, so I think this is definitely the right account of death's harm. And it's important then that there are important arguments out there that the futures of severely intellectually disabled neonates contain far fewer goods than those of typical humans, and that all neonates persist as future selves to a much lesser degree than older children and adults. And just in the interest of time, this is going to be the part I'm going to focus on responding to in this talk. It seems that there are certain things that are very good for us, of which severely intellectually disabled individuals are much less capable, and I think that's fair. Greatly explanatory knowledge, objectively complex achievements, and cognitively sophisticated relationships and communication, we're capable of those to a much greater extent than severely intellectually disabled individuals. Now, some conclude from this that the severely intellectually disabled benefit much less from living, and that's kind of the core argument of Jeff McMahon and Dominic Wilkinson. So, for example, we're forced to look at this is Wilkinson saying we're forced to look at an infant's ability to benefit from things that are often believed to be objectively valuable in human life. These may include knowledge, communication, the development of deep reciprocal relationships, or the achievement of goals and ambitions. Many of them are considerably limited or prevented by severe intellectual disability. Similarly, McMahon claimed that there are forms of peaks of well-being accessible to individuals with highly developed cognitive and emotional capacities, which cannot be attained by individuals with lower capacities. The profoundly cognitively impaired are incapable, for example, of deep personal and social relations, creativity and achievement, and the attainment of higher forms of knowledge, aesthetic pleasure, and so on. Their signal misfortune is thus that they are excluded from many or most of the various dimensions of a good life. Whether or not that's true, that because these things are good for us and the severely intellectually disabled don't have them and therefore they can't benefit from living very much, that depends very much on why you think this stuff is good for us. So there are at least two accounts of what makes knowledge, inquiry, achievement, and relationships beneficial for us. The one that McMahon and Wilkinson seem to be presupposing is what I'll call the objective complexity account. All else equal, an individual benefits more from an activity, achievement, or relationship if it has greater objective intellectual or aesthetic merit per se. That seems to be what they're thinking. So since the intellectually less able are much less capable of meritorious activities, in this objective, complex sense, on this view, they benefit far less from living, right? That's one view you could have. There's another view you could have, though, which is what I'll call the joyful engagement account. So on this account, an individual benefits from an activity, achievement, or relationship to the extent that it fully and richly engages her faculties in the ways that positive psychologists these days have argued flow and mindful experiences beneficially engage us. So by flow, I mean deep absorption in the task one's performing. And by mindfulness, I mean vivid attention to present experience with minimal evaluation categorization of its objects, being present for the actual moment and not just being distracted. So authors like Mihaly Csikszentmihalyi and Kirk Brown and colleagues have argued that these are actually some of the best experiences we can have, and it's because certain of our activities involve these kinds of engagements with the world that they are so good for us. On the joyful engagement account, since we are more cognitively sophisticated than the severely intellectually disabled, we often need to participate in our activities, achievements, and relationships in more intellectually complex ways in order for them to involve the same level of stimulation, personal challenge, and emotional intensity that the cognitively less able can obtain from being fully engaged, challenged, and invested in intellectually simpler activities. And there's actually been some studies of those with intellectual disabilities and how they can, in fact, in their own ways, be very engaged in these beneficial ways, or ways that are deeply beneficial according to the joyful engagement account. So there have been studies on quality of life enhancing interventions that examine joyful engagement among individuals with profound intellectual disabilities by BMA's group. They found that leisure activities, preferred activities, and social interaction increase positive emotions, expressions, and vocalization. Multi-sensory activities and enjoyments increase levels of interaction, engagement, and attention, and increased training or work at task increased competence involving a kind of personal overcoming of personal challenges. Might not seem like a lot to you, but for them, it's a real personal challenge in the way that for you learning physics might be. So studies of the domains of quality of life of individuals with profound intellectual disabilities have documented these individuals' abilities to form intimate bonds with their family and support staff, their preference, and they have clear preferences, strong preferences for contact and company. They have abilities to interact and communicate choices, and the capacity to develop their skills, for instance, related to personal care. And while there haven't been explicit studies of the flow and mindfulness concept in those with severe and profound intellectual disabilities, there have been in those with mild to moderate disabilities, intellectual disabilities, and they seem to be able to do it just like the rest of us. So explicit studies of flow and mindfulness in individuals with mild to moderate intellectual disabilities have found, for example, flow in learning to play musical instruments, performing simple musical tasks for those of you who are actual musicians, right? But they involve individual optimal challenge, and they induce that kind of intense, engaged experience that's so wonderful when your work is going well and when you're really into something, right? Similarly reviewed in Chapman and colleagues, mindfulness training can help reduce stress and aggression in individuals with mild to moderate intellectual disabilities, just like it can in the rest of us. So it seems that they're able to have that deep present awareness of the current moment that is so hard to get these days with all of our technological distractions, but seems to be such a great thing. If the joyful engagement account's correct, there's no reason to think that the profound, severely intellectually disabled benefit less from life than we do. McMahon and Wilkinson's arguments just don't go through. But if the objective complexity account is right, then maybe they do, as McMahon and Wilkinson say, benefit a whole lot less. The objective complexity account does have what I think a lot of us might find on reflection to be very implausibly elitist implications, even outside of the issue of severe intellectual disability. So it entails, for instance, that intellectual and artistic geniuses like Einstein and Picasso or whatever, they benefit far more from life than we do simply because of their gifts. Even when exercising their gifts is no more stimulating for them than flow is for us when we work in our less gifted ways on the things that genuinely intellectually challenge us. So even when we're really into learning that basic physics, right, even if Einstein's kind of like bored and not having a great time, but he's doing super, relativity theory and discovering that's actually better for him than this deep, rich, engaged experience is for us. So a lot of us might find that very implausible. But there's actually an important argument in favor of this objective complexity account. And this is what I call the million argument. This is that the objective complexity account is correct because we should prefer not to become intellectually disabled. And this supports the conclusion that we're experiencing a much higher quality of life than those who are intellectually disabled. This comes from Mill's defense of our cognitive sophistication giving us an inherently higher quality of life because, in his words, no intelligent human being would or should consent to be a fool, and in the 19th century, fool could mean someone with an intellectual disability. It's better to be Socrates dissatisfied than a fool satisfied, right? I think that that's an argument, but there are some initial, I think, clear problems with it. So first of all, when you think about becoming intellectually disabled, there is this issue of transition costs that those who are congenitally intellectually disabled don't even have to deal with at all. So acquired disabilities disrupt valuable activities and induce stress and depression, but those with congenital disabilities never have to bear these costs. That's actually a distraction about the argument. Also, unreliable effective forecasting. So the non-disabled, it's been documented, misimagine less abled life. They think it's way more frustrating and full of suffering than it really is. They fail to appreciate how enjoyable and stimulating and free from suffering it really is to those who have been born into it or adjusted to it, right? Maybe that was actually going on with the framing of the account of how functional disability was in itself suffering in the Groningen Protocol, right? Another problem with the Millian argument when you're thinking, oh, well, geez, I don't, I don't want to become intellectually disabled, right? It might be for other directed reasons. So we may reasonably wish not to become disabled in order to better care for our family and for third parties, right? You can do a lot more when you have these fancy intellectual disabilities to help others. And then finally, there's the issue of instrumental effects. And I think this is actually very important. So we may reasonably wish not to become severely intellectually disabled because in a world like ours, being intellectually disabled makes it much harder, in fact, to live a joyful, or at least it makes it somewhat harder, I'll say, to live a joyful and engaged life. And I think that is a fair thing to say. So I think we may need to admit that those with severe intellectual disabilities can expect to have a somewhat harder life and I think maybe somewhat fewer benefits, although Elizabeth Barnes, I think, has done a great job challenging the extent to which this is so, and my argumentative strategy in this last bit is going to follow her some ways. If the joyful engagement account is correct, they're not going to have radically fewer benefits, the radically fewer benefits that would come with their completely being incapable of most of what's most valuable. So for example, I think a good analogy here might be poverty. We should want not to become poor, but life isn't radically less of a benefit for the poor to the extent that death isn't a serious harm to them. I think that might be maybe what we should say about problems with the Millian argument if, in fact, the joyful engagement account is correct. So to control for these other directed and instrumental concerns, I think it's helpful to consider what I'll call the thought experiment of solo utopia. So suppose you were the last sentient being ever to exist, and you had unlimited resources, including optimal robotic help with basic self-care, and you might have either of the following equally long lives. So first, you could have the typical life. You're intellectually typical. You find enjoyment, fascination, challenge, and personal in scientific, philosophical, or artistic endeavors. Or disabled. You're intellectually disabled, but you find equally great enjoyment, fascination, challenge, and personal in simpler activities, tasks, and choices. And to offset transition costs, we could say, suppose the disabled life is just a little more enjoyable. Would the typical life in this far-fetched scenario really be better for you than the disabled life? To me, it seems it wouldn't. To me, it seemed I'd be equally well off in either of these scenarios. Right. And for the rest of you who might not be on board with me, to avoid status quo bias and smugness, also compare genius, the equally lengthy life of some greater human or alien genius who finds our intellectual and artistic endeavors boring, but who finds equal enjoyment and challenge in activities with greater intrinsic intellectual or aesthetic value. And this also might have let's say this has slightly less satisfaction than typical. So it doesn't seem to me that the individual living genius is any better off than we'd be living typical, or that we'd be better off living typical than disabled. And that might suggest that, in fact, the joyful engagement account is fine, and there's nothing inherently better about higher cognitive capacities. Still, if you were given a choice, I am sympathetic, and this is in a certain way, this was part of Mill's idea. I am sympathetic to the idea we should choose to live the genius life over the typical life, and the typical life over the disabled life, even though that wouldn't be any better for us. Because genius and typical seem to interact with more awesome stuff, right? So it's like, wouldn't it be awesome to be some alien who can just comprehend the inherent nature of the universe in ways that we can't even imagine? I think that would be awesome, and like that would be a reason to choose to be that alien genius, or to be cognitively enhanced to be that alien genius. But I don't think that would make us any better off if we'd be just as fascinated doing the sorts of cognitively simpler stuff that we can do. So what, I think it's okay to choose genius or typical over disabled, but I don't think the disabled are inherently worse off. What's going on? Well, a justified choice of genius over typical and typical over disabled doesn't actually establish that the objective complexity account is correct, or that the severely disabled benefit radically less from life. So authors like Stephen Darwall have argued that what we should want to do with our lives can come apart from what most benefits us. For example, we should want to keep our promises and avoid dishonor, even if we benefit more from breaking our promises or dishonoring ourselves. themselves. Darwell sort of has suggested, and I think he's absolutely right on this, is that the issue of what most benefits someone is not one of what we should most want for what she should most want for herself, but what anyone should want out of rational, including non-myopic, care, sympathetic concern, or compassion for her. We call this the rational care approach to well-being. The question of well-being is very that affects the deaths, harm, and the ethics of killing. It's a very specific one. It's not just about what kind of life we should want for ourselves. And as I've argued in my own work, it makes sense to want to do things with our lives simply out of intellectual curiosity or aesthetic appreciation, because certain things would be awesome. But out of rational compassion for someone, we should care intrinsically or independent of its further consequences only about how much her activities fully and joyfully engage her, regardless of their objective merit, which vindicates the joyful engagement account. Of course, in a world anything like our own, as opposed to this far-fetched solo utopia, doing things with greater merit has enormous instrumental value for oneself and others, in the same way that not being poor has enormous instrumental value for oneself and others. Because the joyful engagement account is correct about what makes an activity, relationship, or achievement beneficial in itself, the severely intellectually disabled are not hopelessly excluded from what most benefits individuals in life. Death harms them significantly. So out of rational care for the poor, we should still strongly want them to survive even if they lack the instrumental benefits of sufficient wealth. Although they may face more difficulty, they can still achieve the kinds of important the same kinds of important benefits that those with enough can achieve. Similarly, out of rational care for the severely intellectually disabled, we should strongly want them to survive even if they lack the instrumental benefits of greater abilities. Although they face more difficulty, they can still achieve the same kinds of important benefits as us. I really don't have time to address this issue of whether neonates persist as the same individuals as adults. So McMahon and Tooley, McMahon on top of this thing about lower quality of life, he follows Tooley and he argues that because neonates don't bear the same psychological relations to their future selves that we do in terms of episodic memory, number of beliefs carried forward, ethical views, self-conscious ideas and plans and stuff like that, they persist as future selves to a much lesser extent than us. They're not exactly the same individuals over time. Like when a baby grows up, it's sort of like a new individual is there, right? It's not like quite the same individual persisting over time. Again, I don't have time to give a detailed argument here, but very briefly, I'll just say that I think arguments similar to those I've given against the objective complexity account and in favor of the joyful engagement account can be used against this view and in favor of the view that because neonates' future selves inherit their capacities for beneficial experience from them in the way that authors like Barry Dayton and Tim Bain have argued with phenomenal continuity or continuity of the same experienced producer, to the same extent that ours do, neonates persist as future selves to largely the same extent as us. So with that in place, here then is my argument against selective non-treatment euthanasia. So first, death's harm does matter, right? The strength or moral reasons to preserve or omit ending someone's life, at least if she can't give competent informed consent, is determined by the extent to which death harms her. So there are powerful moral reasons to preserve or omit ending her life just in case death will seriously harm her. But death does seriously harm them. Death does seriously harm severely intellectually disabled neonates for the reasons I've given. So there are powerful moral reasons to preserve and omit ending the lives of severely intellectually disabled neonates. Which, in ways similar to the interests of other neonates, older children, and adults, can outweigh the weaker opposing interests that they or we may have in not preserving their lives.
Our final speaker is Dr. Christina Lamb. Dr. Lamb holds a Bachelor of Science in Nursing, a master's degree in bioethics, and a PhD in nursing research. Her program of research explores how nurses and other healthcare professionals understand and practice clinical bioethics. She addresses conscience-driven care and how conscience and conscientious objection are meaningful to professionals in healthcare practices as explicated through qualitative inquiry and ethical analysis. Drawing on the importance of ethical workplace environments and patient care provision, she aims to support clinicians' ethical practice through formal, ongoing, and research-based ethics education. In addition to her primary research interests in ethical care delivery, education, and qualitative research methodology, she focuses on vulnerable groups and moral agency in pediatric populations. She has clinical and research experience in pediatric and global health communities. Dr. Lamb sits on international committees regarding the human right to conscience. Her presentation title is Infant Euthanasia and the Clinician's Conscience, Implications for Ethical Practice. Please join me in welcoming Dr. Christina Lamb.
I am going to talk quite a bit about the concept of conscience. And to do so, I'm also going to be really focusing on the healthcare professional from their perspective as the acting person who is looking and exploring the issue of neonatal and euthanasia in relation to conscience. And to do this, basically, I'm going to follow the following structure. I'm going to look at the moral meaning in life and frame the issue by situating the moral meaning and the questions that we ask about that are necessary to start exploring individual particular ethical issues. The ethical issue I will then, of course, outline is neonatal euthanasia and the healthcare professional's role in terms of being a moral agent and the actions that we perform, and by way of breaking down structurally what the parts of a moral action are. Then what is the role of conscience in moral decision making? So we had to explicate clearly what conscience is, and I'll spend a bit of time to do so. And then we're going to take that and apply using conscience to address the ethical issue question. And then, of course, that will show some implications for professional practice, and my intent is to finish with some stories to motivate us forward. So what is the moral meaning in life? Fortunately, I had some of my prior presentation colleagues segue and say that, okay, we have to kind of contemplate some of these big questions when we talk about morality. Why is that? Why is that particularly the case for neonatal euthanasia? Because when we talk about ethical issues, when we talk about bioethics, which I'll explain in more depth momentarily, it's the sciences, but it's also an integration of other disciplines to help us fully comprehend the issues that we're talking about and we're going to address. So I bring in theology and philosophy as a bioethicist. This is what I do, and this is my contribution to science as well. So what is death, and what does it mean to die? What is the context of death in healthcare? The context of death for neonates? What is life? And therefore, what does it mean to suffer? What does it mean to experience pain? Are they the same? And how far do we go to alleviate those two human experiences? You note that I have an illustration here, and this is the story of the death of Abel by Cain. It is a biblical story, but it serves well throughout the ages to remind us of our actions and the implications that they hold. The story goes like this. Cain and Abel were brothers. Abel was the younger. He was the joy of, his family. He was beautiful. He was pure of heart. He was the golden boy. They both decided one day to offer sacrifices to God to give thanks for their, pretty good existence, and God favored the sacrifice of Abel. So in a fury of jealousy and rage, Cain slaughters Abel. And I picked this picture because I think it's fascinating with the juxtaposition of light and dark. And this is important to remember, two significant, issues of note for this picture. You have Cain who's thrown back, and he's cowering over the dead body of his brother, whereas the light shines on Abel, the one who was innocent and killed. And Cain is thrust by the weight of his actions, and the light from the heavens seems to illuminate Abel. And the story goes like this. God speaks to the heart of Cain and says, "Where is your brother?" And Cain says, "I don't know. Am I his keeper?" And as he works through his conversation with God in his heart, he realizes he is his neighbor. He committed something immoral, a wrong act, and is thrust for the rest of his life wandering in remorse. We're going to come back to some implications from this story as I move forward. How does this relate to the ethical issue of infant euthanasia? Because we have to talk about the meaning of our actions when we talk about moral actions. And when we discuss euthanasia, it is important philosophically, scientifically, theologically, as humans, to define things because language has meaning. So when we talk about infant euthanasia, we're talking about the deliberate ending of an infant's life by a healthcare professional. Typically when we talk about euthanasia, today, contemporarily, this is the meaning. And the rationale by far and large, well, you've heard many discrete rationales. I'm just going to bring it together a little bit for the context of my conversation with you and say that the rationale is to end perceived infant suffering based on a lack of perceived worth. And I choose my language deliberately. So we're going to talk about those perceptions a little bit down the road and what they mean. And I offer the contrary position for any Thomistic fans in the audience. On the contrary, I would say, life has meaning because it is dignified. It is inherent to human existence to be dignified, to be human. And our lives are necessarily dependent across our lifespan, everybody has been, will be, or is to some extent dependent on somebody else. And this can be qualified ethically to the virtue of compassion. So compassion is from Latin to suffer with. 2 anecdotes. One being, I gave a talk to about 500 youth in the spring about euthanasia, and it was a bioethics-related conversation. And I asked these high school age students some questions, and they asked me questions in return that made me think, I want you as my grad students one day. But they said to me, I said to them rather, has anybody ever suffered? Again, I'm a scientist, I believe in some numbers and statistics. Almost everybody across the room, 500 youth, raised their hand. I said, okay, do you know anybody else that suffered? Almost everybody, again, raised their hand. I said, have you helped anybody who has suffered? Again, almost everybody raised their hand. And then I said, have you ever asked for help when you've been suffering? Significantly fewer people raised their hand. This notion of dependency jars with the notion of autonomy, which I'm coming to. Second anecdote. I had the privilege of speaking at a conference, an international nursing ethics conference a couple years ago with Dr. Cinda Rushton, who is an incredible bioethicist from Johns Hopkins School of Nursing. And she was doing some work on compassion and empathy, and she was really focusing on empathy in healthcare professions and why we focus on empathy, the walk another person's shoes. And I said to her, why did you choose empathy over compassion? Because she delineated those two concepts initially at the outset of her presentation. And she said, well, because empathy is easier for us to understand and compassion is quite hard and we're not there yet. So I think there's something to be said for the virtue of compassion, qualifying, again, I'll recap, our human existence, which is inherently dignified and dependent. Now, I will make the distinction, this does not entail a vitalistic approach to life, which is a bioethic principle, which is, perhaps save life at any cost. No, we talked about that, we touched on that, my colleagues have touched on that, in the sense that sometimes it is ethical to withdraw non-life-sustaining treatment and or aggressive treatment at, let's say, at the end of life, when treatment is actually causing more harm than palliative care. It is never unethical to have palliative care. Rather, I would say my, on the contrary, position, and I have to be quite broad given my timeline today, but it denotes that life is worth living, it has meaning, and should not be intentionally, deliberately ended. Why, Christina? Does it matter how we treat life, if we deliberately end it or not? Because why do we act? This is the story of the Good Samaritan. Many of you may be familiar with this, but I want to touch on this again because I think that it bears good witness to healthcare professionals' moral agency today. So for example, the story goes like this, and you can extrapolate the contents to be applicable in present day. For example, there was a man, beaten, broken, bruised, lying on the road, dying, and many strangers passed by. Nope, I'm not gonna engage with this person. Nope, I see them, but I don't see them. They're just somebody who's over there. This isn't part of my life, my role, what I want, my responsibility. I'm gonna keep passing by. So many people kept passing by. And then one man stopped, saw this man, encountered him, and said, wait a second, I'm going to get off my horse, I'm going to tend to him, and I'm going to take care of him, plop him on my horse, walk away with him, and give him further care. Give you a car, whatever you want these days. But that's the essential moral of the story. How does that matter? I think healthcare professionals particularly have a role to play in being a good Samaritan on a day-to-day basis. And why is that? Because I'm going to explain bioethics a little bit to you in terms of where it's situated in healthcare practice. So ethics, by far and large, is ancient. Some of my colleagues have already touched on that in the sense that they mentioned, Aristotle, Plato, it's gone all the way through the centuries, and Dr. Liao gave us a nice, kind of timetable of many of the different philosophies that have occurred throughout history and eras. But ethics is a trunk of philosophy concerned with right action. So it actually matters how we act. Our actions are intended towards something the good, the morality. So our human actions can actually be moral actions. Where bioethics comes in is to particularly address the ethical questions that relate to healthcare professionals and healthcare practice. So mid-20th century profession that came together specifically to keep the humanity within the sciences. So what does this mean? It means that many bioethicists, now I've lived and worked and studied in Canada, the UK, the US of A, and done some work in Africa as well. And I would say by far and large, Canada's the country that doesn't routinely take into consideration philosophy and theology and our ethics. You can dispute that with me, but at the same time, the concept I'm going to talk about, conscience, is something that I've been more easily been able to talk about in other countries because of that context. So, why does that matter now? Because we're going to talk about morality, and we had to define things again, because remember I said language has meaning. So morality is that which corresponds to the good and influences our actions. It's kind of a precursor to our actions. So the things that we think and believe that are right and good and true, we will do them, hopefully. And why does it matter to do what is the good? Because it aligns oneself with the truth. And we're going to, when we talk about the truth, that is the good in its entirety, and it's in infinity, and it's metaphysics, and many times we consider that and we attribute that to God. So we do talk about God, we do talk about the meaning of life and bioethics, and many other disciplines as well, but I wanted to make sure that that was clear moving forward. And why does that matter? Because healthcare professionals and healthcare professions have a moral dimension, a particularly moral dimension. Florence Nightingale, I'm a proud registered nurse, and worked many years in pediatric oncology, where I took care also of dying children. Mother of modern nursing, Florence Nightingale, has said that nursing education has to be of a moral nature. And codes of ethics are one way to kind of signal the fact that we do have a strong tie to the moral aspect of our profession and our practice. What does it mean to be a moral agent as a healthcare professional? Things I've already said, to do the good. Our actions can be moral, they can be immoral, so they can lack good, and they can ultimately be evil, which is no good at all. And those are just basically, and that goes for everybody in humanity. These are philosophy 101 concepts. So moral actions are deliberate, and I want to talk about that a little bit more, and I'm going to break down the parts of moral action momentarily. Our moral actions have consequences, particularly moral actions, because we can also talk about the universality of morality, which I'm going to get to momentarily as well. But for right now, what I want you to walk away with from this slide is that there is this notion that morality is the good, which is ordered to the truth, which is outside of ourselves, and therefore every person can correspond universally to morality. The last point I had in the slide here are the parts of moral action. So they're denoted as the object, intention, means, circumstances, and consequences. Some of my colleagues already touched on really amazing principles such as the principle of double effect. They talked a bit about intentionality and some of these other points. I will focus on all of them, but I will also explicate the object more clearly. So some of the perspectives of neonatal euthanasia that might promote you to act in favor or against it. I'm fully aware that people are probably on a variety of agreement points with neonatal euthanasia, but right now I wanted to flesh out some of them that have already been talked about, but elaborate a little bit differently on them. So there's a notion of autonomy, which is, hey, it can be a good thing, self-determination, I get to decide what I do with my own body, and to some extent with the bodies that are in my charge. This can be based on preferentialist bioethic, which is kind of espoused by people such as Savulescu at Oxford, Shuklink, a few other people like that. And it's kind of this vague notion of ethics which is predicated on, well, this is what I prefer to do with my life or not prefer to do, and you don't have a whole lot of answering beyond that. It's a vague form of utility, utilitarianism, which is concerned with the most good for the most people, but it can reduce people to a social net worth. We can talk about the fact that within these perspectives, oftentimes it is discourse issues whether or not they're beneficial, whether or not they're burdensome. Suffering can often be described as meaningless, and they don't appreciate the fact that there's dependency in humanity. And truth is what I say it is. So Dr. Liao kind of touched on this point with some of his existentialist, more modernistic explanations of approaches to life and the meaning within it. And what we can kind of err a little bit on this side of the screen is to this notion that truth is what I say it is. My life is my own life's project. In that sense, I don't have to stop by the side of the road and help the man like the Good Samaritan did. The extreme could be resulting in, the first slide, the depiction of how do we align ourselves with our actions and our intentions. On the other side of this slide, we talk about the notion, a worldview, if you will, a philosophy, a bioethical perspective of acknowledging intersubjectivity. So as human beings, whether we're healthcare professionals, whether we're patients, families, caregivers, etc., society, members of society, stakeholders of healthcare at large, we live in community. We live amongst each other, especially as healthcare professionals. We practice with each other. We engage with patients. We engage with babies. This can be supported by a notion of solidarity. And then again, coming back to compassion, this notion of suffering with, because once again, suffering is a human experience. You're rarely going to find anybody who has not encountered it. It's something that can unite us and draw us to each other as rather a point of separation. And how we view suffering, again, will come into play when I talk about moral actions. Again, we're dependent. And this kind of signals a responsible liberty. The reductive liberty on the other side is kind of, okay, freedom is what I choose it to be. My freedom is just solely the sum of the choices that I make for my life, and it leads to radical autonomy that doesn't necessarily engage with the suffering individual in front of you. However, if you can understand, or you can take the worldview that, hey, there is moral meaning to all our lives because there's something universal about living, something universal about suffering, something universal about dying, well, then maybe we can talk about a responsible liberty or freedom, which asks us to go outside of ourselves. Quick, simple explication of that, you're the Good Samaritan. And this speaks a little bit about to be aligned to morality in that way is to be truth-seeking, and that aligns with conscience. And what of conscience? I've done quite a bit of work on conscience and a research study recently on conscientious objection with nurses in Ontario, and I've talked to a lot of people about conscience, and sometimes it's that, good or bad angel on your shoulder, but there's quite a bit more to it. I'm not going to go through this whole slide, but it's meant to do is illustrate that since Aristotle, we've been talking about conscience. And most philosophers worth their salt will talk about conscience. And as we move through the age and some of those stages that Dr. Liao took us through, it's quite relevant in Aquinas, Kant, Mill, Newman, and contemporaries, Heidegger. Edith Stein talks about it. There are many have left off this list, but you can see we're still talking about it today with more philosophers. Right now with Claire, but we could throw in quite a few more there, Ratzinger, Ronheimer, Newman, etc. I need to explicate conscience a little bit because it's actually quite a complex concept, which isn't to say that people couldn't get it, but it's actually something very interesting because something very interesting about it is that in most of the literature pertaining to ethical decisions and ethical issues in contemporary healthcare literature, philosophy, bioethics, etc., we don't talk about conscience. And if this topic were about conscientious objection, which is kind of one of my main areas, I would say that it's quite an anomaly that we don't talk about conscience because conscientious objections or COs are an act of conscience. So I'm just going to take a couple of minutes to move through this slide and explicate what do I mean by conscience. And I'm going to use a framework that was created by Thomas Aquinas, who was a medieval philosopher and theologian, but to my mind at least, no one has really touched on it as an explicit way as he has, regardless of how long ago he wrote it. So what is conscience then? We had to define that. So it's the application of moral judgments to particular cases. So we're making moral judgments. This isn't the don't judge me that we talk about a lot socially now, but it's like every human being has the capacity and ability to make, I'm speaking kind of universally, there are qualifications, but to make moral judgments about the things that they should or should not do. And where does this moral knowledge come from? When we talk about moral knowledge, it's important to make distinctions between types of moral knowledge. The first one is quite universal. So Aquinas tells us, for example, Dr. and I was talking about life in general is quite good, death can be a harm, so let's not go around killing people as a general, let's say, moral absolute that's universal. And what Aquinas says is if morality and moral issues become more complicated the closer they get to a particular situation. So he says, for example, you had to move from higher reason, universal knowledge, to lower, more practical, particular reason. And he explicates this as an example of drowning. For the sake of time, I'm going to skip over that because I think it's something you can, grab for yourselves off the slide. But I want to also make this distinction about kinds of conscience because I think that is very important when we talk about how we perceive conscience and how we consciously decide to do things. Because some people may say, well, my conscience tells me to do something exact opposite of someone else's conscience. And McIntyre, as Dr. Liao mentioned in Notre Dame, he does talk about moral impasses and how you can kind of grapple with them. I would say there's something very fundamental to moral decision making, though, however, particular by way of conscience. Remember, everybody has a conscience. As Aquinas is laying out, everyone has this ability to conscientiously make decisions, moral decisions. But it depends on whether or not your conscience is formed, unformed, ignorant, or deliberately so. What does he mean? Well, he's saying, for example, you may grow up in a household where your parents said, don't hit your sister, or be respectful to your teacher, don't lie and don't swear, and they're telling you and they're showing you how to form your sense of self, your moral self, and how to make decisions. There may be people that haven't gone through that, maybe they're lacking, let's say, some kind of particular general formation throughout their lives. There are some people who may go throughout their whole lives and not encounter that type of parenting or mentor or opportunity to think through some of their actions, and you could say that that's an ignorant conscience to some extent. There are those who won't want to. There are those who say, I don't want to bother myself with thinking about morality or ethics, and I deliberately stop my conscience from making those connections. So interestingly enough, though, conscience is something that binds us in the sense that we have a duty and obligation, because we have a conscience, to make moral decisions and then to follow through in those judgments. And Daniel Smacy from Georgetown talks about how conscience is also a fundamental commitment to morality that each of us can make, and then we have to follow through. When we know something is right, we have to actually act on it. And as I've reiterated in slides before, we can know it is true by understanding that morality is good by defining terms philosophically, and also through elements such as natural law, reason, revelation, or aletheia. Aletheia is going to come back in a moment, but it's essentially a Greek word that's used in phenomenological research to mean unveiling, which is the way that they describe truth. Okay, so how can we apply conscience to address neonatal euthanasia? Well, we can ask ourselves, we can go through a series of questions. What is the moral question? Is it moral to kill or euthanize infants? For example, we're applying universal moral knowledge to a particular situation in doing this. And we can rely on the parts of a moral action to help us decide that. So as I mentioned before, and you can read off here, so for the sake of time, I'm just going to move through each of the components of a moral act. We talk about the object, and that is what it is you want to do, what it is you're going to do. So let's use the example basically of euthanasia. And let's use it in physician, let's say, death, in the sense, let's say you have a physician or a nurse practitioner who's actually going to administer the lethal injection. And you can say, okay, well, they want to, let's say, end suffering. Okay, but the means that they used to do is lethal injection. The circumstances are in a healthcare scenario. So you have a physician, you have a patient, it could be the neonate, and the consequences are they're going to end in death. So it's going to be a harm of some sort to this neonate. Your intention is, while it might be to alleviate suffering, the means that you're using to do so are a lethal injection. Whereas if you wanted to, and we've already talked, my colleagues have already talked about this, but if you wanted to, for example, alleviate suffering, why do you need to have a lethal injection to do so? And the parts of a moral act will explicate this. Couldn't you rather have palliative care? Couldn't you rather have titrated doses of analgesic, pain control, to be able to bring about that and reconcile the object, which is to alleviate pain and suffering, with your intention was to bring that about through the means of palliative care? Your circumstances and your consequences remain ethical in the sense that death didn't occur, but suffering has been alleviated. So then you can also you can ask yourself, if you're unsure, does this act correspond with what is universally moral and good and true? And again, if unused to this type of philosophical inquiry, you can just think to yourself, Good Samaritan. Universally, we can recognize there's something good about getting off your horse or out of your car to help somebody who's suffering, because you understand that suffering is a human experience, and that every human person you encounter, and yourself included, is dignified, dependent, and can be made good through compassion. Does the act correspond with being humane? Remember, in bioethics, we talk about keeping humanity in the sciences. And what are your rights in practice if you're trying to practice conscientiously? So I'm going to shift that focus a little bit and talk slightly more about conscience in a different capacity. I'm going to, broadly stroke some of the different aspects of conscience. It's actually a human right. So the Universal Declaration of Human Rights and Freedoms in 1948, when it was first declared, they put down in Articles 1 and 18 that conscience was a human right. In our Canadian context, where we're talking about, we've legalized medical assistance in dying, and we're kind of talking about mature minors, and we haven't approached neonatal euthanasia, but I think it's safe to say that's going to be on the table in the near future. Conscience is a human right and is actually protected in the Canadian Charter of Rights and Freedoms. Human rights are, especially the absolute human rights, are universal, incommensurable, and they denote duties as well as obligations. So, and it's actually recognized throughout at least the Western world in terms of healthcare practice as being necessary for healthcare moral decision making and worthy of protection. So human rights violations can occur if it is not respected, and if it is violated, remember, conscience is something we all have. It's part of our human experience. It's something intersubjective. We can share it. So if we talk to people that don't believe, let's say, my conscience tells me this and my conscience tells me that, Edith Stein, phenomenologist, 20th century philosopher extraordinaire, feminist, nun, and victim of Auschwitz, has said that conscience, there is something communal about conscience. So we can recognize and go out of ourselves when we talk about conscience and making conscientious moral decisions about the actions in our healthcare practice. So it's not just about autonomy, it's about that responsible liberty. It can require moral courage, again, bringing in virtue ethics, and needs to be acted on. With the short time I have left with you, I just want to share with you a little bit about my Aletheia Conscience project, because I know, as I touched on at the beginning of my presentation, conscience isn't talked about that much in healthcare. And if you want to talk about conscience in healthcare, you can talk to me, you can talk to my research team, and because part of the work that we do and the way forward for attending to conscience in healthcare practice, remember the title of my presentation, so outside of explaining it, talking about it, how it relates to making moral decisions, how that relates to this particular situation in neonatal euthanasia, my aim and the aim of my research team was to protect the human right to conscience for healthcare professionals, attend to voice, and to do this in various modes of further research, webinars, etc., roundtable discussions. I'm going to finish with a story because we always have to move forward, and I think stories can explicate concepts quite nicely, especially if they're new. Not assuming you don't know anything about conscience, perhaps you could verse me on conscience, but at the same time, I know for a fact, because of my research indicates that conscience is not something we talk about or fully understand. I'm going to take you back to 20th century Nazi Germany. Sometimes we over-rely on Nazi examples, but this is one I think explicates conscience quite nicely, which is why I specifically chose it for this presentation. I'm going to take you to the context, which I already said, and it's about university students who were driven by their conscience to respond to the extreme socialist regime. You might be like, hey, Christina, this is out of context. We're talking about neonatal euthanasia, but I'm further explicating, okay, for example, though, how conscience is so necessary, this is what it can drive someone to, and this is how they can maybe be an example for us to move forward and fully understand it. They created leaflets as university students and illegally distributed them around campuses because at that time, freedom of conscience wasn't allowed, freedom of expression wasn't allowed, freedom of religion wasn't allowed. And basically, the Nazis also ran euthanasia camps and they killed disabled people. So I thought that that tied in very nicely to Dr. Nye's presentation. And we're talking about oftentimes the reason for neonatal euthanasia is this notion of we're competent. This is actually, I think, a very good explanation. So when Sophie Scholl, this is the picture of her, and I'll let you read what's there on her slide, she and some of her friends and her brother were arrested, tried in an unopened court, and guillotined. And she had this to say to the judge, Byrne, who read off her death warrant. She said, "You will soon be standing where I am now." And the Nuremberg trials, if you know anything about them, made her prophecy come true. So she says, how can we expect righteousness to prevail? She's talking about universal morality. When there is hardly anyone willing to act, be a good Samaritan, to give up himself, herself individually to a righteous cause. Think about this in the context of should we legalize neonatal euthanasia? Such a fine sunny day, and I have to go. But what does my death matter if through us thousands of people are awakened and stirred to action? So today you heard different perspectives. You may be aligned with a certain perspective. I have respect for that. I think that going forward, though, when we talk about this, knowledge is empowering and it requires us and impels us to act. So my questions to you in finishing this is to please invite you to go forward, reflect, and think about those actions. And are they going to be, and truth I think is quite simple, defined as never competent or entirely dependent? And based on that, what will you do? Thank you.
I would just like to remind the audience and the panel to discuss this issue in a tone of civility. Rebecca and I have done 4 years of transferring patients, and we will break up any wrestling matches that occur. So we have 10 votes for this question. It's directed towards Dr. Nye. Questioner is asking if you're aware that it's difficult to find neonatologists who will define an infant as comatose or brain dead due to the unpredictable nature of neural development, no matter how impaired.
In some ways, this sounds like it might be a better question for some of the empirical experts about exactly what goes on with those diagnoses. If I'm being asked about like the ethics of that, of we don't know whether an infant is comatose. Just in my sort of stock philosophical examples, I was talking about being extremely sure that a patient was comatose and it being fine to withdraw treatment under those circumstances. In real life, one has to be extremely careful because the stakes of making a mistake and withdrawing treatment or euthanizing someone who is not irreversibly comatose, who could go on to live a great life, are enormous, right? So the costs of being wrong are just astronomical. I think we need extremely good evidence that someone is irreversibly comatose before withdrawing. So I would, from that decisional perspective, I would advocate extreme caution, and think that it is well worth a certain amount of resources, keeping someone alive and doing the diagnostics. I mean, what I am somewhat familiar with is the case of those with locked-in syndrome being mistakenly diagnosed as being unconscious, or having lost the capacity for consciousness. And luckily, I understand there's use of fMRI machines to try to work on this. But yeah, I mean, withdrawing treatment from someone who is there is just a huge cost. So we have to be extremely cautious. And I'm sure some of the empirical experts could tell you a little bit better how that works in practice, which unfortunately I don't know that much about.
I think you also have to define very carefully what you mean by comatose. And as Dr. Nye pointed out, there could be locked-in syndrome, there could be persistent vegetative state, there could be brain death, and how do you qualify brain death? Higher stem cell, lower stem, brain stem death, and those sorts of qualifications. So I think part of it's just acquiring the appropriate knowledge, and sometimes you don't know what to ask, so it's great to start by asking very good questions, but there can be layers and levels and degrees to which the question has to be answered. Interestingly enough, a woman in Denmark, I think, at some point this year, woke up after 10 years in a locked-in state, and she could hear everything that went on. And during the whole time that she was, apparently comatose. So there are actually quite a few cases like that.
So I'll just mention it in the neonatal context, because babies have open skulls with soft spots. You can't really talk about them being irreversibly comatose. They can be profoundly comatose, they can be profoundly brain damaged acutely, but if you wait long enough, in the vast majority of cases, that pressure inside the skull on the brain will improve without irreversible brainstem damage. The problem in older patients is if they get massive brain swelling, the skull is a closed box, and then the brainstem itself has a high risk of developing irreversible damage leading to death. The newborn or young infants whose soft spot is still open are quite different in that respect.
The next question we have is, what is the underlying moral and or legal basis, by what authority, for euthanasia legislation?
There's quite a few responses to that to try and keep it somewhat focused. Oftentimes these movements are very socially driven, and sometimes they're actually they're driven by social minorities. So sometimes I think it's a combination of factors. I think it could be a genuine desire to end suffering, but I think that if we had, as I think it might have been you, Dr. Byrne, pointed out, palliative care is really vastly underdone here in Canada. For example, I do work in pediatrics, and I think the most recent numbers from pediatricians who studied across this country in 2016 released a study saying that I think it's more than 50% of children who could require or access palliative care here in Canada don't. So I think there are many things that motivate legalization. Here in Canada, for example, the process was a lot of social pressure put on the Supreme Court, raised by many activist groups to kind of get this going. And I know a lot of people that are involved in the process leading up to it and in my research, actually, from nurses who have made conscientious objections to euthanasia in practice, I mean, sometimes it also depends. I think we like to believe that there's a lot of goodwill and people are trying to do the right thing, but I think sometimes social agendas, to my knowledge, can take over. And some nurses have said that they have refused or didn't want to participate and were part of the socio-political legal process leading up to legalization or the decriminalization, for example, of the part of the criminal code and charter, and said that their opinions were just silenced or they weren't listened to. So I think there's a lot of things, a lot of factors that go into it. Ultimately, I know, for example, that in Canada, it was legalized at kind of a tricky time politically speaking because or the time leading up to it was a federal election. Technically, in terms of power authority, the Parliament could have kicked it out with a notwithstanding clause. So I think what you have in Canada, for example, the context is a push for it. You had a lot of, unanimous decision by Supreme Court justice. So is it necessarily, I'm of the opinion, and I stand on the fact that not everything that's legal is right. I mean, I talked about Nazi euthanasia programs and that sort of thing. There were actually euthanasia programs prior to the Nazis enacting it in the United States put on by eugenicists. So I see a lot of things across my desk too. I don't just get influenced. I know there are a lot of people that do advocate for euthanasia for eugenics purposes and killing off, population control. They want to kill off the elderly. So I have quite a specific line of approach when I take with that. So I'll just have that be my contribution.
I think that there's two, you could sort of categorize it into two. I think there's a very sincere concern with suffering at the end of life, real physical suffering at the end of life, and worries about the effectiveness of palliative care, and a sense that there isn't, when we know that the results are going to be the same, some of these distinctions about doing, allowing, and intending, foreseeing really aren't very morally important. So especially if what's being done to end someone's suffering doesn't harm them on net, and especially if they consent to it. And that's another entire, I think, moral leg of this with assisted death for adults is the respect for autonomy bit, or the support for autonomous choice bit. At the end of life, even with ideal palliative care, it can be a burden. And I think there's a thought that for mature adults, there is a real autonomy issue about whether they should be allowed or whether we as a society should support them in dealing with the end of life in the way that they choose for themselves. I think that has to be balanced against all of the kinds of concerns about the very serious harms that can come from having this. I also, in my views, I tend to be a little more optimistic about the effectiveness of palliative care for dealing with real physical pain and suffering. So the autonomy part, I think, is very real, but that actually doesn't apply when we're talking about neonatal treatment. They're not able to give informed consent. There isn't really concern in this case for autonomy. We have to make decisions about their best interests all the time anyway, to take them to the dentist, just to change their diapers, to do everything, right? There isn't an independent autonomy concern, so to the extent that part of the rationale for assisted death for adults really is, and I think some of the strongest part, really is the autonomy part, that the case for extending that to neonates is pretty weak on those grounds.
With respect to the autonomy perspective, as I mentioned before in my work and my research with healthcare professionals, even though they're not mandated per se in Canada to participate, the healthcare professionals' autonomy is something that's not always considered in the euthanasia issue. For example, when you do request, and I'm completely empathetic and compassionate towards those who are suffering, and I do strongly advocate for palliative care, and as Dr. Nye says, the better use of it. Pallium Canada, for example, I put in a plug for the great work they do, but the healthcare professional, their autonomy also should have commensurate rights because of the right to conscience. So sometimes we don't consider all facets of the issue when we're legalizing euthanasia, because in fact, we are saying to some people, aka healthcare professionals, you have to now kill somebody.
Just for anybody that's interested in actually following the kind of discourse that happens at the public level, pay attention to the kind of language that people use. Pay attention to the kinds of conceptions that people have about what a human person is supposed to be. Because ultimately, the authority that you're going to derive, or the authority you're going to kind of use in any discussion is going to come down to something at the end, right? Whether that's reason, feeling, something divine, or arguably anything that doesn't rely on anything else is your divine principle. When you pay attention to that, you begin to see why certain authorities matter to some people and some authorities don't, right? If you are thoroughly an existentialist, you don't think there's any structure to the world. Reason is this kind of nebulous entity that's sterile, and it doesn't kind of appeal to the longings of your heart. Those kinds of when people reason about euthanasia, that's not really going to make much appeal to somebody, as opposed to someone who's like, well, it just feels wrong, or something along those lines. There's an interesting book called The Conflict of Visions, written by an economist named Tom Sowell, and he talks about how there are two kind of visions of people. There's an unconstrained vision, and then there's a constrained vision. And he talks about this more in the context of like government and those sorts of things. But what you envision people are supposed to be, whether we're inherently fallible and life is about mitigating kind of the negative effects that we can have, as opposed to a more utopian understanding of what a person is supposed to be and the kind of society we can create. Those are assumptions that are hard to empirically ground, because even the empirical evidence you'll find you have to interpret through a lens. Pay attention to the kinds of things that people talk about when they're talking about, oh, well, this life isn't worth living, et cetera, and then you begin to understand what those underlying assumptions are. And I think in any kind of conversation about euthanasia, those are the kinds of conversations we need to have. We actually need to be talking about those most fundamental assumptions, because that's why we have so much conflict and we can never talk to one another, is we're appealing to different kinds of authorities. So we need to have a conversation about the authorities in the first place.
Our next question is directed towards Dr. Byrne. There's actually two questions. The first is, have you ever encountered a situation of parents inquiring about medical assistance in dying for a neonate? And the second is that, in your experience, does the fear of hastening death using opioids ever prevent physicians from adequately sedating a dying infant? How do you deal with this?
The short answer to the first question is yes, very infrequently, and in the clinical situation where treatment is either life-saving treatment is either being, so all the kinds of discussions we've talked about have occurred, and it's recognized that the baby is dying, life-supporting treatment is being either limited or withdrawn, and because of some kind of physical appearance of the infant, usually with gasping, breathing after being taken off the breathing machine, parents get very understandably distressed, despite being prepared for all of this likely to happen. There's a lot of difference between being prepared for it and then seeing it actually happening. And so in that situation, I've been asked by fathers exclusively, never by mothers, to do something to stop this, or please do something, and using language like, you wouldn't allow, an animal to suffer like this. And of course, the approach then is to try and help them deal with what's going on, in addition to manipulating whatever medication you can to try and decrease that sort of breathing. And also explain to them that in that situation, this is way more difficult for them, because the baby is almost inevitably deeply unconscious because of the prior deteriorating condition. And so the parents are actually suffering greatly, but the baby is not. The second question?
Does the fear of hastening death using opioids ever prevent physicians from adequately sedating a dying infant?
Well, so it shouldn't, because standard treatment and standard teaching, there are all kinds of protocols about the appropriate way to deal with these problems. But given, the variation in practice between individual practitioners, I'm sure there are some practitioners who worry, in terms of conscience or whatever, that they're in a much more difficult situation. And my advice has always been in those situations that if you have difficulty in doing this part of your practice, then just consult somebody else who's more comfortable, for want of a better term, in doing it. It's the same as we would do in many other aspects of our practice.
If I could just add on to that quickly, Dr. Byrne. For example, the comfort level. I think sometimes it's very true that in healthcare scenarios, having practiced in pediatric oncology, there are different roles that we play as members of healthcare teams. So I can remember, talking to people that maybe they weren't as comfortable as ordering medication, regardless of if it wasn't necessarily a conscience issue. And by that specifically, I mean I knew my patient needed more pain medication, and sometimes you just have to say, for example, to the other person who may not be comfortable ordering it, well, maybe you should bring in palliative care. Trying to get more disciplines involved is necessary, and just everyone trying to communicate, because I think sometimes it's, what can augment an issue of conscience is more knowledge. So sometimes just being able to feed that fear with more knowledge can empower you, and it may not be so much a conscience issue as a lack of understanding or knowledge too.
So the next question is a pretty sensitive question. In the same way that parents may choose to abort a child with special needs, isn't legalizing euthanasia for infants opening the door to killing babies who are not terminally ill but simply unwanted?
I know that, for example, we talked quite a bit about the Groningen Protocol, but something that I, talk about quite frequently is the importance of language and the meaning of language and defining things. I know in the Groningen Protocol they define the situation as hopeless. But how do you find a hopeless situation? I read once in a study with outcomes from the Netherlands how some couple had asked for their child to be euthanized simply because they had a cleft palate. I mean, I'm not saying that all the statistics are aligned with that information, but especially since when you talk about what motivates people and some of the perspectives that do exist out there, there are people that do think that those that are disabled should be euthanized. So I can see that being a possibility.
Well, the language is worrisome, opening the door and floodgates and all of that sort of thing. I worry about that in the language in the question. And undoubtedly, there is a worry about that trend. But I think how one deals with that is that you ensure that, as Howard talked about, that the most vulnerable are protected appropriately, completely indifferent to their potential intellectual capabilities or whatever, that there's a fundamental respect for babies who are born to achieve whatever life track that they can achieve. And you build all the safeguards around that so that even in situations where parents, for understandable reasons, it's very easy to discuss these things in theory. It's much more difficult if you've given birth to a child with, vastly different physical appearances or capabilities than what you expected. But even in that situation, I think you build in safeguards, professional standards, and then obviously legal safeguards to protect the child.
My sense is that, on the empirical questions of just, will this kind of policy change lead to this sort of thing? I think it's important to actually look at the evidence. One thing with the treatment of disabled newborns is I actually think that things have gotten, at least within the philosophical discussion, much more sympathetic to the disabled over the last, say, 50 years. You might recall in the 80s, it was actually, there were practices going on of withdrawing or withholding at least life-sustaining treatment, in some cases withdrawing even just very basic, withholding even very basic life-sustaining treatment from infants with as mild an intellectual disability as Down syndrome, right? So this was aired and sort of this was countered with the baby doe legislation. And I think the bulk of the medical establishment is not okay with selective non-treatment or euthanasia for anything as mild as a mild to moderate intellectual disability or Down syndrome. What I'm arguing against, the selective non-treatment and selective euthanasia of profoundly and severely intellectually disabled infants, this is sort of in some ways the last bastion, some might say an ableist, the last bastion of this, of this selection on the basis of intellectual ability that's been going on. And if you look at the philosophical literature from, say, 50 years ago, it's calling them defective newborns. It's talking about their physical appearance as almost reasons to not treat them, and it's far more sympathetic to those with disabilities now. So in a certain way, I actually think things have gotten much more sympathetic. Again, with the Groningen Protocol, we have to look at the evidence. The floodgates did not open. There are 2 cases under it. It was accompanied, probably for independent reasons, by a decrease in active euthanasia. As much as I am opposed, or I have these deep moral objections to selective non-treatment and euthanasia, I don't see it being something that's spreading from the severe to profound case to other things. I think we should argue against it, and I'm doing that, but I don't see it spreading. And I would just say with abortion, we can have, I think, very different views about the ethics of abortion. So some think that abortion is very different because of the mother's autonomy as carrying the baby. So Judith Thompson, right, has argued this, that even if you think death harms, fetuses to the same extent it harms you and I, right? She thinks that abortion could be justified on those grounds. Now, if the fetus is viable, she says, maybe not. I think that there's actually good reasons to think that early term abortion, before you actually have a mental individual, is a very different category than someone who already can experience the world and can continue forward and experience future goods. I actually don't think that empirically or intellectually there's a lot of reason to think that what's going on in the abortion debate is necessarily going to directly influence what's going on in these other cases. We really should treat them on their own merits, and I think we can do so reasonably.
I would just add to that after birth abortions are illegal in the United States, so that would be technically, you could look at that empirical aspect of it and say that that is technically infanticide. And at the same time, the abortion is something that is quite a sensitive topic to address, but I would say that, there is empirical evidence to acknowledge that life does begin at conception. So if you do have a knowingly like an unborn baby that is going to probably die due to anomalies, then you can also support through that death and dying process, and you can get a palliative care consult. I remember the work when I was a clinical ethics fellow at MD Anderson Cancer Center in Texas, and one of the things that was quite big at that time was trying to usher in palliative care consults for pregnant women that knew that their child would be born stillborn or probably would die very quickly after birth. So there are reasons to say empirically that you don't necessarily have to kill the unborn child in relation to those aspects. And the last thing I would like to draw attention to, the question I would like to raise, is whether or not with the Groningen protocol, if it's not legal, is it regulated? So do we really know how is there a reporting system? It's a question I have. Maybe somebody else in the panel could answer that for me. But if it's unregulated, how is it reported?
So just one thing, I think, yes, bare biological life does begin very early, but if you're someone, so the kinds of arguments I was actually giving towards the end, I think that what makes someone a subject of interest over time is actually being the same center of experience, center of valuable activity, and that there's good evidence that that comes in somewhere. Could it be as early as 20 weeks, but definitely by 24 weeks. So that's why some of us might have a different view. Think that abortion is in another category. I didn't know what you meant by saying after birth abortion in the United States is legal. Could you just clarify what you meant by that?
Yes, I believe, to my knowledge, it's in some states that you can deliver a baby and then still choose to have it aborted at that time. So it's technically termed after birth abortion.
Something really important to think about is what are the implications of the kind of decisions that we make. And maybe I'm just going to be this guy today that's always talking about taking a step back. Whatever criterion you're going to use, if it's suffering or whatever, at the end of the day, you are going to have to ask questions about life itself and whether or not life is something that you can or cannot kind of mess with or end. If you think there are cases in which ending life is permissible, you got to look at the kind of justifications that follow from that. I think we're actually in some ways more logical than we think we are, and in some ways we're not. And by that I mean not looking at individual people, but if you look at the trends of thought in history, of how we've adopted kind of largely in our culture that kind of existential life, I'm talking about YOLO, all that kind of stuff. Those were ideas that kind of trickled down to us from the Romantic movement, right? And from philosophers like Nietzsche. This is 100, 200 years ago. Parts of that kind of trickle down to us in ways that we don't necessarily think, but they show up inevitably in our ethics, which is why I think issues like euthanasia, so on and so forth, these criterion of suffering, and being able to end life when suffering is high or whatever, why those kinds of ideas are now permissible to us are because ultimately the foundations on which we understood whether life is something that you could intervene with, like to cause death towards, those are rooted in ideas that have trickled down to us. So there is something to the floodgates idea, but before you go there, you have to think about those underlying ideas that we aren't talking about that have actually influenced to make us even think that those kinds of things are permissible in the first place.
I'm just a bit confused, Dr. Liao. Can you give an example? I mean, for example, when you're saying that to me, I can appreciate that there are certain values or philosophies that certainly have made their way down through the centuries. For example, infanticide was rampant in ancient Greece, but Hippocrates, when you read the Hippocratic Oath, they swore an oath to the gods to never kill. And actually, in fact, that is still something that is and they said they would never cut as physicians. So it's actually kind of interesting because I both worked and studied in the UK, and they take that still to the letter of the Hippocratic Oath, and surgeons are not called doctor, they're called Mr. or Mrs. because surgeons cut and physicians don't. So I just wondered if you can maybe give me a bit more of a specific example, because I understand that our worldviews can be rooted in certain philosophies, but if you could just distill for me what it means, why one over the other in centuries, I'm not entirely sure where you're going.
Sorry, if I could just interrupt there, I'll add that on to some other questions that have been asked.
Sorry.
Specifically to Dr. Liao, in situations like this, when there's opposing worldviews at play, how do we know which one to operate under? How do we know what is right in a pluralistic society? And another question, if you wanted to get into, is how do we define quality of life?
The question of which worldview is the right one, so to speak, actually is going to come down to the internal workings of the worldview. And I think that the fundamental principles you need to adopt in your worldview have to make sense of reality. Okay, and so they have to make sense of everything else. I think a theistic worldview makes more sense than a non-theistic worldview, because I think when you talk about principles of rationality, when you talk about the basic necessity, like when we use logic, those kinds of things, I think they have to be rooted in something, and I think they're rooted essentially in God. Whereas in an environment kind of that tends more towards atheism, you have kind of atheism that believes kind of in these metaphysical things that are non-natural, but you also have atheism that's purely naturalistic. And if you believe in a purely naturalistic atheism, I think it's harder for you to kind of argue for things like logic, whatever. I don't know that those kinds of questions are going to be resolved easily, and I don't know that this is the forum to, I don't think this is the forum to address those kinds of things. But from a practical standpoint, this is where I think the work of Peter Berger and Charles Taylor is really helpful, is at least in realizing that there are different kind of plausibility structures that we inherit nowadays that make us kind of uncomfortable with beliefs that we maybe held a lot more strongly before. The possibility of different beliefs are always kind of pushed on us now, whereas if you lived in a more kind of homogeneous culture, you wouldn't, some of those kinds of things would be harder for you to imagine to even be plausible. But living in a secular, we live in a pluralistic age, but particularly in certain circles, we live in a secular age. Charles Taylor talks about this idea of cross pressures, and that's basically just the sense that there's unease about where we are because we feel some sense of transcendence, and yet we live in an immanent frame, so there's no such thing as a transcendent realm. There's a kind of fullness that we experience, but we don't know how to explain. I think worldviews are going to have to be able to take into account those kinds of sentiments that we have, and they can, they evolve through time. The conversation that I kind of don't want to have, but I think we probably should have behind closed doors and with one another, is whether or not those first principles are things that we can hold on to, and how those first principles kind of work out into things like ethics.
Can I just make a kind of pragmatic comment about that? So, as Lester said, and it's been echoed, we have lived in a predominantly Judeo-Christian world, and there are many newer influences more recently, which personally I feel very positive despite my Irish Catholic background. In a very pragmatic way, sometimes influences and forces that we don't truly think about very much have a massive effect on what really happens. The example of Jehovah's Witnesses infants who are born and who may require a blood transfusion to survive. And I have been in the unenviable position over the decades I've practiced where I have had to go to court to have a newborn infant taken away from her parents in order to have a blood transfusion. And I remember specifically more than once the judge saying to me, "Are you absolutely certain that this blood transfusion will save this baby's life? Because what we're doing is," he didn't use these words, but essentially we're trampling on the spiritual beliefs of these people. And I've said, no, I can't be certain that this will save the baby's life. And sometimes it did, and sometimes it didn't save the baby's life. I remember saying to one of Howard's philosophy colleagues, if there were 34 million people in Canada who were Jehovah's Witnesses, and there were 1 million people who were other religions, then we wouldn't be giving babies blood transfusions.
Did they still give you the transfusion in the cases where you said you weren't absolutely certain?
Yeah.
Did you? Yeah. Okay. So you clarified you were certain enough. Yeah. That's good to hear. Yeah. I mean, I guess I would just say I think that what we have to work with are our views about what's ethically plausible. In my experience, when we really get down to the fundamental things about suffering independent of further effects is a harm. Hey, here's some arguments for ordinary experience being a benefit. Those things can really be independent of people's background, metaphysical views. I actually think they lead how people interpret their theological views. You can go back in the Old Testament. There were some Judeo-Christian individuals who they were kind of cool with infanticide when they were sacking the Elamites or whatever. They changed their views over time, and I think that's wonderful. And I think by the time you got to the Christians influencing the Roman Empire, they had these wonderful views about equality, and they were stopping gladiator fights, and they were adopting babies, and I think that was a wonderful thing. But I really think that it wasn't very maybe it happened to be that they were getting their insights by thinking in religious ways in certain ways, but there's no essential connection. People do horrible things in the name of religion, people do wonderful things in the name of religion. What ultimately drives them to pick some particular thing out of their religious inheritance are going to be things like their ethical views, and those, fortunately, are the sort of things that we can influence with ethical arguments. So the sorts of arguments I was giving, I would hope, could persuade someone who didn't think that the lives of the disabled had value, completely independent of their metaphysical views. And if they said, oh, look, my religious text says that babies don't have value, if there was such religious text, I said, look, here's all these other things your religious text says. You don't believe those ones, so why believe in this one? It's because of your intuitions. And here, I'm challenging your intuitions. So honestly, I don't really think that these background metaphysical assumptions are very important in practical ethics. I think that our practical ethical and normative ethical arguments really are the leading factor, and then how people decide to interpret their religious tradition really just, it shapes around it. Sorry.
I think there is a distinction to be made, particularly in an era where religion is something that's not quite talked about, and sometimes it does actually get relegated to the back, is that faith and reason are not separate. Just because you are religious does not mean that you cannot qualify your philosophical perspective with theological views. In fact, if we had more of a liberal arts education right now, we would see that many disciplines actually integrate to eradicate ignorance, and they can actually fuse together quite nicely. I've encountered many people from a variety of religions who are able to absolutely reconcile very rationally their viewpoints, and I think what it comes down to actually is not so much the people, but being truth-seeking and trying to define what the good is, and then following through in that to be consistent.
And actually, I think it'd be interesting for us to talk more about this later. But one of the things that I would kind of throw out there, for example, would just be the entire. You use, for example, the idea that we need to talk about things rationally. Why do you need to talk about things rationally? If you believe that your feelings kind of dictate things much more than rationalism, it's going to be hard to have a conversation about what's the right thing to do. And you see this specifically in the realm of vaccine hesitancy, right? You can show people as much empirical evidence that vaccines are positive, but if they don't think empiricism is a means by which you're ascertaining true knowledge about the world, no amount of evidence is going to convince those people, right? So when I say that ethics is impacted by our worldview, I think you see that most clearly on the wide realm, like through the philosophy of, like the history of philosophy, as opposed to the individual level, because I don't think, and that's part of what I'm trying to say, is most of us don't actually think about those assumptions, and I don't think we're perfectly rational beings either. I don't think necessarily the things we do necessarily match up with what we believe about X, Y, Z. So
this conversation is so interesting, but just to bring it back to kind of the topic at hand, we're going to move on to a few more questions before we wrap it up. There are a few questions here, particularly about the role of parents in ethical decision making in NICU. So one of them is, being that parents have to be the caregivers for their children, in your opinion, what role does parental wishes, resources, and capacity to care for their disabled child play in neonatal euthanasia? Another question, as a professional, it can feel like you're continuing care for the family's sake. So who are you treating ultimately, baby or family? Whose well-being is more important?
The last part of the question is easy to answer. So, you obviously worry about the effects on the family, you worry about the capabilities of families in all kinds of ways, but fundamentally the focus of care and life-saving treatment is based on the interests of the child. There's been a lot of argument over the years, certainly, about how does one define the best interests of somebody who can't express their own interests, and we could spend an entire session on that, I'm sure, without any difficulty. But you try and do that in focusing, first of all, on the intrinsic value of life, as had been said earlier, that the survival of the child is the fundamental goal. And then as the costs of that survival, in terms of many, many different other things, start increasing and increasing, and I guess the likelihood of the survival starts decreasing and decreasing, that's where you try and do some kind of balancing act between the benefits of what you're doing and the harms of what you're doing. Because one of the unfortunate realities is, and this has been described by several of my colleagues here, when you're in this situation, you are an actor. You are undertaking acts, both positive acts and acts of omission which contribute to the survival or the death of the patient. And so you're not neutral in any of this, but primarily your focus is the welfare of the baby.
So there might be others on this panel who are a little more in the know. My understanding was that there were provisions for cases, and like maybe the Jehovah's Witness one doesn't sound like necessarily be it because they're happy to care for the baby after they get the transfusion, right? I thought there were some cases where if parents refused what we would regard as just basic essential care, there are provisions to take the child and make them a ward of the state, right? So I mean, look, here's what I would say ethically: if McMahon or Wilkinson were right, that death really doesn't harm severely intellectually disabled babies that much, then I could see how you might want to say, well, look, the parents, it should be the choice of the parent, seizing the child and making it a ward of the or finding an alternate caregiver would not be okay because they might be grieved, and it doesn't really harm the baby that much to die. If my arguments are sound, and death really is a severe harm to them, in the way I've argued, then I do think that you're looking at a situation that would be like these other cases where, look, most of us would say, if parents don't want to care for their, 2-year-old or 4-year-old or 10-year-old, they just, rather have them killed. We'd say, no, that's not cool. We're going to take the child, make him a ward of state if that's absolutely necessary, find alternative caregivers. And I think if what I've said is true, is sound, that's really what we should say about severely intellectually disabled children, that if the parents, look, I know realistically it probably will be the parents, and I think we should do everything we can to give them appropriate support. I hope that's something we could all agree on, that, much more, serious at-home care. I think there's a lot more we could do in Canada. We're in an extremely affluent society. We could offer a lot more to the parents of these children who realistically, under normal circumstances, will bear these burdens. Honestly, if I'm right, and they're not willing to bear those burdens, I think that this would be a case where we'd be justified in taking them and making them a ward of the state. Sorry.
Just to conclude here, we're wondering if each speaker can give a minute summary of any closing remarks and maybe touch on the question of what now? Where do we go from here in terms of the prospect of neonatal euthanasia in Canada?
So just in closing, I've argued that for one of the main cases in which the various individuals want selective non-treatment and selective infanticide for infants who otherwise could live, it's not a good idea. My sense is, and I think some of the other panelists have argued that in other cases of dying infants, palliative care is sufficient or can be made sufficient. So I think that neonatal euthanasia is something that we do not need. I do think that an essential part of that is that we need to revisit practices of selective non-treatment of severely intellectually disabled infants. If we're not okay with their active euthanasia, I don't think when they could live otherwise, I don't think we should be okay with their selective non-treatment when they could live otherwise either. So I certainly hope that we don't adopt anything like the Groningen Protocol. I hope that we'll revise our guidelines to take out things like severe intellectual disability as a grounds for the kind of hopeless quality of life or whatever that's currently allowed to justify non-treatment, even when the baby would otherwise live.
Well, I think I would just reiterate that when you're making moral decisions, and whether it's around neonatal euthanasia or these other defining factors, I think that it's important to really talk about what those moral actions are and what they mean and what your goal is in enacting them. And so just kind of pulling back a little bit and tending to things like conscience. And I say that because I think that there is a lot of work that can be done to communicate better as healthcare professionals amongst each other, amongst families and with their patients about these serious issues. I'm going to borrow a line from this fabulous nurse in the United States, Ann Hamrick, who's done a lot of work on moral distress in nurses. And she kind of says that, we have to not talk about issues of, in her research, moral distress, only when we're in a situation of crisis. I think what we really need to do is try and make more efforts to make conscience part of our decision-making process, and recognizing that we can conscientiously respond to issues morally, ontologically, as well as empirically, and just to have those conversations together to kind of try and decide a bit more about where to go further. And for practical explications, I would say that I think I would agree with Dr. Nye in the sense that there's more work that could be done in palliative care. There's a lot more work that could be done in supporting families. I did look at the Canadian Pediatric Society's survey that they sent out to the physicians and asking them if they had ever received requests, much like the question was asked of Dr. Byrne tonight. And part of me wondered, because I'm a qualitative researcher and sometimes we can't get all the information we need from a survey, but at what point were those parents felt driven that they had to, or that they wanted to ask for their infant to be euthanized? Are there more supports we could offer them?
As neonatology has evolved over time and become much more successful at keeping babies alive, in parallel with that, there has been an openness of discussion with bringing parents and nurses and other healthcare professionals into these kinds of discussions when the clinical course starts starts deteriorating. I think that's a huge progress compared to the days when I was training, when that discussion was very paternalistic. The attending physician essentially decided what the chances of survival were and had a very clear discussion with the parents, which was informing them that the baby was going to die. I'm very optimistic. It's very much more an open discussion. And I think because of that, it's very unlikely that a kind of one-sided movement to introduce neonatal euthanasia is likely to happen. It's very unlikely to happen.
It's important for us to think about those underlying presuppositions that we have that inform the kinds of beliefs that we have when it comes to ethics. And I think that's a conversation that we need to be having. I know it's difficult from a pragmatic perspective, but today we just kind of looked at the intellectual history. I think one of the next things that we would have to look about is actually and this is a great point that Dr. Nye brought up, there is a disparity, I think, between what we believe and necessarily how we act. I mean, you can tell yourselves a million times, a million reasons why you shouldn't eat the chocolate cake, but you'll still do it. There's a gap between what we believe kind of in our heads and how we actually act. That's kind of the next piece of the conversation that I think we need to have in regards to how our worldviews then filter down to what we do. And I think, honestly, everybody should read the book by Jonathan Haidt. It's phenomenal in helping us understand, especially people from different cultures, when they believe in things that are like sacred, as opposed to, there's nothing sacred, or just the opening our minds to those kinds of possibilities. Because I think inevitably, once we're able to broaden our perspective, the conversations will kind of flow from that, as opposed to when we all kind of may or may not have a more similar line of reasoning.
Well, it's certainly been a very heavy night of a whole bunch of different ethical conversations, but I'd ask that we give our speakers a round of applause for the excellent presentations that they put together. We would like to present you with gift baskets for your contributions. And to honor the work that you've done in preparing for your presentations, our conference planning team has made a $300 donation to urgent needs at the Stollery Children's Hospital in your name. To once again thank our generous sponsors who made this event possible, and specifically mention a few volunteers, including Rebecca Stanley, our MC, Rebecca Yang, who has put a tremendous amount of work into organizing this event, along with Emma Foreman, Kennedy Grant, and Maui Castro, and a special thank you to Dr. Nye, who led our planning efforts in putting this together.
I would also like to thank Kiana Owen for organizing this event and also for being a fantastic co-MC.
And we just want to give a quick thank you to those who tuned in our live stream, and all of you for being such a wonderful audience. This concludes the symposium, and we hope that you're able to continue this conversation, whether it's in your clinical practice or in academia or in your work as a student. So thank you so much. Have a good night and drive safe.